Welcome everyone to the Cornwall and Scilly NHS Integrated Care Board. Is it really a fortnight since we last met? It's just gone so quickly, and it's so good we thought we'd meet again. This is the first public meeting, effectively, we're having. So welcome to all of you. Welcome to those of you as colleagues who are here for the first time. And I'll pick up some of that in a second, but we've got a bit of a packed agenda. I also wanted to say some colleagues are leaving to go and do some other things. So Kate will be with us until 10:30? Yeah. So I'm going to move the agenda around a little bit just to accommodate some of that. Due to the rising COVID rates, we have decided, as you can well see, to have a fewer group of people here, of which I am assured by each of you, you have done your lateral flow tests and you're all okay. Yes, thank you very much. And like I say, we do have the members of the public at some point. I know some of them may be joining us, but we have no public questions. If I can welcome, first of all, Joe. We had Helen here last time, but Joe, my understanding is you'll be standing in until your organisation gets as the community secretary or your new chief executive. Is that right?
Yeah, that's right.
Yeah, lovely. And welcome.
Thank you.
Welcome into the room, Debbie. Thank you for testing us last time, and I hope you're all right. And Ali, welcome to your good self as well.
Thank you.
You are our overall council partner representative here. And of course, Andy, you are now our primary care and partner in that medical care space. So welcome to you. And I think everybody else was here last time. And colleagues may be in the room. Okay, so moving on. For those of you who weren't here at our last meeting, just wanted to say one of the disciplines of going through these meetings is we'll take the papers as read. So unless it's headed presentation to be presented, we won't be asking any of the executive groups to speak to them, but we will be asking you to respond as appropriately. So moving on, declarations of interest. Has there been any change or anything updated, or anybody new who wants to comment on anybody else's declarations? No? If not, thank you. We'll take that as done then. I've been told there are no questions from the public, so we're going to move on swiftly to the chair's update. So the chair's update is a little bit more in two halves, one a formality and one is a different point altogether. The formalities are, of course, we met on the 1st of July for the first time as an integrated care board, and there are certain elements of that which we need to note and in order to formalise them. So you have in your board pack the appendix 1, and you have my chairman's update. And I'm just going to work on the assumption, unless there's anything in that pack that anyone wants to pick up on, that you're happy with that, and we can proceed. Yeah. Also for the formalities, again, if you have any comments, do raise them now. I don't intend to go through the minutes, but if you have any reflections on those, please raise them now. If not, I plan to take the minutes as of our first board meeting on the 1st of July, as said. Okay. And what we're going to do is ratify those minutes effectively at our first board meeting in September. So moving on, in terms of some of the items in there that I've chosen to feature on, a bit of an apology first of all. The first thing is to spot the own goal I made on the dates. We have in your diaries, everyone, from September. We've said to Kate and her team that we've agreed that we're not having a formal board meeting in August, as I shared with you last time, but we are intending to actually have formal board meetings every month from September, and we'll be talking about the forward plan probably as we go through today. But it's not the detail to get sorted today. We're asking Kate and the team and for all of you to come back in September. So you have these dates in your diaries, but they will be formal board meetings. The other point to raise with you is that we have outstanding action from the 1st of July relating to the legal guidance from Brown Jacobson. And Trudy, I just need, and Kate, to look to you to see whether you have any views on the terms of reference for the REMCOM review group. Do you want to go? You don't need to touch it, just...
All right. So subject to Brown Jacobson's legal advice, I
I note that they're happy for the Chief Exec of the ICB to be part of the review group for the non-executive director pay review. So we'll move ahead with that advice and maybe review in 6 to 12 months' time.
Yeah, and Trudy, if I can just make sure that all the issues of quality and things like that that were raised in the Brown-Jacobson letter, we make sure we have captured in our final terms of reference. Trudy?
Can I just kind of flag, so one of the other changes that we've agreed, so in addition to Kate being a member of that panel and being able to vote, the Brown-Jacobson advice also suggested it was okay for you to chair that group, John. So that's another change that will be made as part of that.
Sorry, you're going to have to say it again. We lost you.
The Brown-Jacobson advice also confirmed that you were able to chair the meeting. So that's the further change that we will make, John.
Yeah, that's fine. As long as everybody's happy with that. And when there's a conflict, I will step back from that. Appendix 1 of the Chair's report lists the expected board dates. I've covered that off. I'm assuming there are no issues on that. I just want for the formalities for you to recognise that and make sure that we're set up for that. Thank you. But one of the other issues I wanted to cover off was the letter from RCHT from the Chair, Mary, and from the Chief Exec, Steve. So what I'd like to try and do is just recognise the fact that it was in the public domain. So we've made sure that you all as board members have access to that. And I didn't know whether there was any particular debate that you wanted to have on that first before I turn to Kate, but is there anything you actually wanted to raise? Yeah, Neil?
Yeah, John, I don't think one could say other than in terms of the content of the letter, the issue of safety is one that we've talked about a lot. And it was good to see that at True North, when Place were debating their part in current issues, Place saw that safety was a major issue for us in this first year of working together as a board. One of the things that I was most pleased about being able to come onto this board was the collective responsibility that's attached to how we seek solutions in terms of going forward with issues like this. And when I saw the letter last week, I was concerned about the issues that are ongoing, but I did feel that the letter presented a particular viewpoint. And as with any debate in life, there are different viewpoints. And for me, I suppose what worried me was that I became aware that it had gone public, in effect. And I would have been hopeful that in going public, what the public worry about is what's going on. They see through things like this problems, but actually what I would have preferred is that we as a board were able to work on this from the outset and hopefully present a way forward and some solutions coterminous with the letter going out. So I'm just making that point because for me, the way we work together is different from the ways we've worked in the past. And the worry with perpetuating different ways of presenting this means that the public at the outset perhaps get the wrong impression of the way we're going to work as an IC board.
Okay, I think before I ask any other comments, Kate, can I just turn to you and get your perspective on what you think we should be doing next?
So I think it's really important that as a board, we recognise that the letter that's been sent to us reflects the reality of the work that we are all doing across Cornwall at the moment, and that there's nothing in the letter that we are not currently working together to try to solve. The letter also talks about some of the national asks that have been made. So we'll talk later on in the agenda today around the high impact changes and the 100-day challenge that we are already on with addressing. And I would just want to reassure our public that the letter might suggest that we're not working together, but the reality is we are. And I think it's fair to say that RCHT hold quite a lot of the anxiety around the risk because of the manifestation of the queue at the front door. But we are all we are all committed and working together to make sure that we get rid of the queue as quickly as possible. And today it was going to be my chief exec's update. We have a small multidisciplinary team based at County Hall who are just working through every action that we need to take together, not separately, together, to make a difference to care in Cornwall.
Okay. Mario.
Thanks, Chair, and thanks for that, Kate. There was a couple of sentences in that letter that referred to, I think it was 32 million or 30 million pounds of funding that went to the local authority to support this issue, and a point that there wasn't clarity on what had happened to that money. So that slightly doesn't chime with what the point you just made, Kate, but I wonder if there's any clarification on that point.
So Steve or Mary may want to come in on this, because this is my understanding of the point that was made in the letter, Mario. So we've got a section 256 arrangement with the council that we put in place at the end of last year. The money that is lodged with the council is for the system to use to work together to be able to solve some of our intractable problems. I think the point that's raised in the letter is, if that money isn't spent, can it be used for our CHT to open a winter ward up? I am very hopeful that by the time we get to winter, we will have home-based care in place. And if we do need to open a winter ward up, I just want to be clear that we will have failed to do what we say we want to do. So the money's there for a purpose. And that purpose will be discharged during the course of the summer and the autumn.
Okay, thank you. Can I invite Ali? Would you like to go next, please?
Thanks, Chair. Excuse me. So, yeah, thank you for that. And thank you for your response there, Kate, as well. And I just wanted to clarify that some of the money that's been transferred across to the local authority, some of that money is ring fenced for the voluntary sector. There's some of that money is ring fence for public health, and the rest of that money, I think as a system, it is critical that we use that to really pump prime that sustainable change that we need to see to deliver improved outcomes for our residents, but also improved flow across the whole system at every point in which it touches our residents' journey. Thank you, Chair.
Okay, let's go to Mary next.
Morning, everybody. Thank you for inviting me along today. For those of you who don't know me, I'm an independent care provider in Cornwall, and I represent Cornwall Partners in Care, which is the social care trade association, for want of a better description, for all aspects of independent social care. I also saw the media article that you wrote, Steve, and felt it was a bit of a missed opportunity, because the letter, as you've sent it through, seems to me to be perhaps putting a little bit too much negativity on the social care sector, which I wanted to flag up, because supporting what Neil Walden said, it was obviously the very accurate description of what's happening in the NHS across Cornwall, which we are all equally concerned about. And the working together is an opportunity here that I think we shouldn't be missing. I felt the missed opportunity was that it would have been helpful perhaps to have said in that something along the lines of work for social care and help to save your NHS, because we cannot look after people in social care without staff. Staff are working in a geographically constrained county. We have water on three sides. We can't invent new staff. We can't compete with the hospitality sector. We've got providers. A provider contacted me over the weekend to say that she's struggling to cover any weekend work because she's competing with changeover days for the hospitality industry. Changeover day used to be 1 day. It's now about 4 days. And everybody's supplementing their income. We're doing an extra day. During the pandemic, we had staff who left social care in order to earn £20 to £25 an hour cleaning caravans. Some were able to save a huge amount in order to then take the winter off. We don't want to see people taking the winter off, because that's the time when the NHS is under greater pressures. Our staff across Cornwall, there's about 16,000 of them, I believe, We also look after at least 5,000 residents in care homes and many more in social care, in care in the community. And so that's a large chunk of the population of Cornwall who are affected equally by the inability to get into Trelisk, if that's what's needed, into ED. We all know there's a demographic time bomb, which is now here. But what people tend to forget is that because of the Pill and the Abortion Act in the 60s and 70s, we've actually got a very much smaller adult workforce. And in Cornwall, people tend to work shorter hours, or they're working in multiple jobs. We're competing with all sorts of things. I could go on, but I think now is probably not the moment to do so. But I just wanted to flag up that with the best will in the world, we cannot invent staff, and safety is a big issue. We cannot admit people or take people into packages of care without the staff to safely look after them. Thank you.
I'll invite Kate to make some comments in a second in a roundup on this, but Martin first, as one of our non-execs, please, what are your thoughts?
Thanks, Chair. Yeah, I mean, my thoughts are, John, that we've got all the right people in the room now, the right people on the board. What I'm looking for, I think, to be perhaps slightly different to what's gone before, is a really clear plan that everyone has signed up to, that we can all be confident and track and hopefully deliver, because I tend to feel, obviously Steve can speak for himself, but the letters are, for me, is a little bit of a symptom of the system as a whole, perhaps not having that explicit plan that we all believe in and we can all try and deliver. Maybe that part of that plan is to open a number of beds in the acute trust. I don't know. It might be a good idea, notwithstanding the availability of staff, real estate and money. But whatever that plan is and whatever it includes, I think that's the thing we need to expose, understand, track and monitor and deliver to enable this problem to be solved.
And on that very point of what next, before we get to Steve, I know, Kate, you wanted to go next. So what are your thoughts?
So that was the issue Mary raised around workforce. So now we've got Patrick in post. Patrick's in the MDT hub at County Hall, looking at the precise workforce needs that people are asking for, to see if we can start matching available resource to gaps in care, and also to start looking at how we can bring people in from out of county. So workforce is at the front of everything that we're doing. And for next year, we have to have supply solutions that puts us in a sustainable position. And Patrick will be able to bring updates on that back in September.
Anything else you want to know?
And so should we let Steve, and then I'll just summarise.
Okay. So, okay, Steve, you go next, and then we'll ask Kate to summarise.
Yeah, thank you, John. Very grateful for that. And thank you, everyone, for the comments that have been made. John, if I could echo your kind of desire and request for us all to work together on this, that's absolutely our intention. And in writing to the ICB, that was our intention, John, so that we could have that discussion and that clarity. I believe colleagues have chosen to put that in the public domain, and that debate in public is absolutely fine and appropriate, but it would be equally important for us to discuss those and progress those in every opportunity. Mary, I don't know what media article you're referring to. I haven't written any media articles, so it'd be helpful to add a session know what that is. But in respect of the points that Mary makes about workforce and social care, that they're absolutely critical, and I certainly recognise those. What CQC said in their urgent and emergency care inspection report in March was staff shortages in social care across Cornwall, especially nursing staff, are some of the highest in England. And CQC said that staffing crisis is resulting in a shortage of domiciliary care packages and care home capacity, meaning people cannot be discharged. So CQC said exactly those things that Mary has said, and that places a huge, an immediate challenge on all parts of our system. So that workforce focus is absolutely imperative. Those things, though, do absolutely result in increasing patients who finish their medical treatment waiting for discharge from an acute hospital. And the evidence is compelling. It is increasing, and that places a threat to our ambulance service ability to respond, and our emergency department ability to operate, and services such as stroke. So from my perspective as an ICB partner member, it's imperative to me that every one of us has the data, the information, and the clarity on these issues, and on the risks that mental health services face and community health services face, and the broader social care sector face as well, so that we can be informed to escalate, to reprioritise, and take decisions moving forward. I think it's really, really important for us as an integrated care board that we have quality, performance, safety and financial information about their health and care integrated care system, rather than information that just refers to parts of that system in the NHS.
Mary, just very quickly, are you able to respond to Steve's question about what media are you here?
I was actually just putting something in the chat. Somebody sent me a link which was either on, I can't remember which the link was, but it was either on Twitter or possibly Cornwall Live.
Kate?
So it was Cornwall Live, and it was a direct lift from the discussion at the RCHT board, and the article was published, I think it was the day after the board, where Steve urged the board to write to the ICB. So that was the article. To summarise, I don't think there's anything that's in the letter that's in front of us that is new to anybody around this table. And I just would hate for anybody in Cornwall to feel that there isn't absolute clarity of oversight of all of the pressures that are in the Cornish system. And in my Chief Exec's update, I'm going to run through them. We know that we need to do work to remove the ambulance queue from the front of RCHT, but that's for all of us. It's not for one sector. Everybody, every part of the public service in Cornwall has something that it can do to make a difference. And we are working together to make that difference a reality. But it is for all of us. And we will be bringing back plans in the public domain so that we can talk through each part of our system. And that will be inpatient areas as well as domiciliary care and care at home, to talk about how we're working together to make a difference for the people that we serve.
Okay. Did you want to say?
I was just going to kind of say that the reality is that if one fails here, that we all fail. This has to be looking at whole system solutions. We've only just started, so let's try and bring the challenges that we all face into the room and find collaborative and creative solutions to them.
Shall we move on to the Chief Exec's update? I'm sure you'll touch on this when you get there, Kate. So should we move on? Any challenges online before we finish? No? Thank you. Kate, over to you.
Okay, so I just wanted to talk about the pressure in the county, which after our last discussion, I will run through it again. We regularly have ambulances waiting outside the front of Scilly Hospital. And what that means for people who don't understand the impact is that for every ambulance that waits, there's somebody waiting at home for an ambulance to arrive. And it can now be up to 5 hours this week for an ambulance to go to a category 2 call, which is somebody who's had a heart attack or a stroke. And for people who've had heart attacks or strokes, it's time limited in terms of getting you to hospital in order to provide the treatment that you need in order for you to be able to get better without ongoing symptoms or indeed to survive. So for all of us in Cornwall, it should be something that we are thinking about all the time. Royal Cornwall Hospitals and our South West Ambulance provider declared a critical incident this week, which means that they are at the highest levels of escalation. And as individual organisations, there isn't anything they can do at this point to make their situation better. However, the rest of Cornwall is at Opal 3, so we have the availability of care to look after people outside of hospital. And what we need to do is to work across all of our services, and that's from care in people's home, it's from reablement in people's home, it's around nursing and residential care home placements, to make sure that we're getting people into the most appropriate place for them at this point. And I suppose as part of my update, one of the things I would urge families is if there's anything people can do to support loved ones to bridge packages of care and to enable people to get home quickly, and that would be in everyone's best interest, not just the relative, but the person who's waiting for the ambulance. And I think it's important to see that in the context of COVID increasing across Cornwall. So at times when infections increase, hospitals become places where infections can thrive because of proximity of people to each other and the rapid turnover of people going through hospital facilities. So again, to reiterate, the safest place for people to be at this point is in their own homes. It's usually the safest place for people to be. But while we have increased levels of COVID in the county, that makes it even more important. We, as a county, we struggle to send people home who are elderly to their own homes without additional support. And that is, there's something about how we provide care in Cornwall that makes us different from our neighbouring counties. So a piece of work that we are starting to look at is why that's the case and what we could do to enable people to live happy, supported lives in their own homes, only using residential and nursing home care as people's care and treatment needs dictate. We've got the multidisciplinary team hub in County Hall, which brings together people from all parts of the public sector, looking at how we work together to get the best possible outcomes for our people. And often I hear in Cornwall that this is a money issue, and I want to be really clear. This isn't about the availability of money. This is around us making sure that we use our workforce in the best possible way. And that might require that we ask some of our people working in health and care to work in a slightly different way this summer. But we'll be asking them to do that for our vulnerable people to make sure we look after them well. So that we're clear about exactly what the problem is that we are sorting out, we've got a team from a company called Prism coming in to work with us. It's nationally supported and it's part of the National Discharge Task Force follow-on work that we've had in Cornwall. So they will be starting with us next week. We think we know what the problem is. This will absolutely clarify what the problem is, where our bottlenecks are, and therefore what working in a good level of detail we're going to do to be able to sort it out. That will allow us to be able to measure impact, Martin, and it will also allow us to know which parts of our system we might need to rebase risk, because I think we worry sometimes about sending older people to their own home, about whether they'll be able to cope. And our voluntary sector colleagues suggest that we don't ask people whether they'd like to go. We sometimes decide for them whether it's a safe thing to do or not. So Prism will help us with that. We have a system oversight meeting on the 19th of July. So again, going back to the letter, this meeting has been planned for about the last 10 days, and it will bring together senior members of the NHS from NHS Improvement in England, along with our colleagues who've carried out the pathway reviews of the National Discharge Pathway team. So we'll be joined by Leslie Watts from Chelsea and Westminster Hospital, from Jennifer Fenlon from the Department of Health and Social Care, and by Kate Mitchell from the Local Government Association. We have action plans associated with those pieces of work, and we're going to be asked what we've done with them. So we will be pulling together a quality impact assessment for Cornwall, and we'll be talking through where we've got to in terms of bringing those plans together from each part of our sector, and then we'll be asking for organisations to give us their individual feedback around how they're pursuing their actions within their own organisations. This is something that we need to address rapidly this summer. We know the winter is going to be difficult for lots of people around our county. We know the cost of living increases are impacting on all families. We know the fuel increases will impact on people's abilities to heat their own homes, notwithstanding that the government is going to have additional grant aid to be able to give to people to keep their homes warm this winter. We need to work with our places. So we have 3 places in the west of Cornwall, in the centre of Cornwall, and the north and east, to talk to people on the ground with our most vulnerable about what's going to make a difference this winter. And we know from the True North event that I'll talk about in the next item that we have 5,729 voluntary sector organisations across Cornwall who are waiting for us to ask them to work with us to help their communities to live happier, healthier lives. And as we move on to the next agenda item, I'd just like to talk through how we plan to do that over the coming weeks and months, and how this is the way that the ICB, the Integrated Care Board, working together across Cornwall, is going to truly make a difference to how our services work together to meet our people's needs.
Thank you. Let's go to Mary first.
Thank you. I just wanted to add that whatever the cost of Louisa Forbes' team for urgent emergency care team has come to, it is money well worth spent. It's made a huge difference to supporting people, giving confidence, giving safety, covers the sector in respect of CQC and other actions. And if that could be expanded so it was 24 hours, that would also be really helpful, although we do have access, separate access through that number to 111 with priority access. So I just wanted to flag that up. It's worked really, really well, and any expansion would be welcome. It does stop people being conveyed to hospital.
So, Mary, I went to Trewidden Care Home in St Ives the day before yesterday because Louisa wanted me to see a gentleman who, fantastic joined up care from the care home to our out of hours provider, to South West Ambulance, to ED, to West Cornwall Hospital and back to the care home. So he presented with sepsis. He was taken into hospital really quickly and he was treated with IV antibiotics and he was home within 2 days. The care home are really keen to work more closely with us, and Louisa's team and the work they're doing, it's really evident that they provide a lot of support to the care sector. And what's also really evident is if we provide support, what an amazing job people do in terms of looking after our older people. It was a real privilege to go and see them this week.
And Mary, you can see why we were so keen to have you representing the sector in the room. Thank you so much. Margaret.
Thank you, John. Thanks, Kate, for the update. I'm really excited to see what PRISM's going to say, because I think that will help just set the tone a bit, particularly around risk, because what we've got to do as a system is to provide some cover for our people, because they are frightened sometimes of discharging and feeling that if something goes wrong, they're going to take the blame. And this is across the county. So I think by having a neutral third party coming in and giving us some advice, then we can, as a system, say, we will take the risk collectively and you as an individual will not be facing the coroner, which is what they fear. I also just want to say that CFT, of course, we face both counties, both Devon and Cornwall. So we're doing an awful lot of work with helping UHP with their flow in the east of the county. And that we are working quite heavily with SWAST and UEC. Our board invited SWAST Monday to come and talk to us. And we are trying our very best to cooperate across the sector and are looking forward to seeing what the PRISM work will send our direction, as it were. So thank you, Kate.
Thank you, Ali.
Thank you. Thanks, Kate, for that update. More of a comment from me, really. Just wanted to reiterate my full support and commitment to drive this forward. I think we have a huge opportunity across Cornwall to really do something different, which delivers different and better outcomes for our residents. Certainly from an adult social care perspective, we're very keen to embrace technology and equipment and see how we can really mitigate the risks for people staying at home while also optimising our very valuable human resources across the county. Thanks.
Andy, and then Debbie.
Just a very quick point in respect to Kate's update. We just recognise that a third of our population gains their secondary care services from across the other side of the Tamar. And as a board, we just reaffirm that we recognise that. We know our local communities, and with Jane on the call and with the public on the call, that we actually recognise that this is a cross-peninsular issue, not just an RCHT issue. No respect to Steve and Mari, we are providing similar support to Exeter, yes, Devon hospitals and to UHP.
If Jane, you're happy to, after Debbie, you might wish to make some comments as well, but feel free to say no to me on that. But Debbie, you're next.
Yeah, so I was really grateful for Kate's reference to us prioritising the most vulnerable, and it would be remiss of me not to point out actually that some of those are people who are living with mental health, learning disability and neurodiverse conditions, and so the impact of how we describe the work that we're doing is really important on them, to give them confidence that we are here for them when they need it. We have in the mental health pathways got some significant alternatives for those that are in crisis, and we do have not ambulance queues, but we do have people who are waiting and being held in the community waiting for urgent mental health support. So we do as a system also need to recognise that urgent and emergency care pressures are not just ambulances, and there are other groups who we are also supporting as a system.
Rachel?
Thanks, Chair. I think, again, a whole system approach, and obviously the immediate pressures on flow are the focus of a lot of work and Prism's work. But I think really important that we know that long-term approach that we've discussed at True North, which we'll come to later in the agenda, but that there's other drivers of demand. So we need to really be looking at those drivers that mean that sort of the big conditions like cardiovascular disease, that people have prevention, that they're supported to stay well. So that is also part of a sort of more sustainable system in the future. I was just looking at the new census data on some of the population figures that have been released for Cornwall, and between the 2011 census and the 2021 census, we do have a 25% increase in our population of over 65 year olds. So that's not inevitable that leads to a system challenge, but let's put it in that's the context that we're in. Just in the last 10 years, that shift, not the highest in the country, but certainly up there. And we need to be really keeping people well, doing that aging well approach and managing conditions well for people to stay at home, as well as the flow issue. And
Andy, just to answer something before I move to Jane, of course, Jane, who is the ICB Chief Exec for Devon, who sits on our board, of course, Kate actually will start to sit on Devon's as well. So there is true peninsular working beginning to ramp up. So Jane, give us the Devon perspective, please.
Well, thank you, Chair. I mean, again, obviously, similar areas of work happening in the Devon perspective, and obviously keen to be working with colleagues just to ensure that we have got that alignment, and I know that's in place. And in fact, we did work with Prism last winter, so we can share some of the learning from that as well. But certainly, obviously, linking with Andy Sant and the integrated care area for North and East is I know that's in train. So the more we can join up, obviously the better, because patients don't confine themselves to their counties, do they? They do flow through, and again, similar in terms of how we address some of the workforce challenges in a joined up way as well. And I know that there's a lot of work happening with LiveWell, particularly in this space, but I recognise that there's more we need to do on that. And I know when Kate comes to our board next week, we'll be having similar conversations.
Last comment, if I may, from Mary on this, and then I'll invite Kate to summarise.
Yeah, thanks very much, Chair. Just really following on from Rachel's point, it absolutely demonstrates the circularity of the issues that we're facing and the absolute codependencies that we have between us. So for all of the reasons that Rachel has outlined and other speakers, I think the issue for us is absolutely to recognise we are carrying risk all over the system. And yes, it is most apparent in some places and least apparent in others. But I think the benefit of this conversation, as other speakers have said, is we are all here in this one room, able to trust each other and hold each other to account for doing everything that we can possibly do. Thanks, John.
Thank you. Before I invite Kate to summarise, just a few questions from you, Kate. When you do come to summarise, you might want to pick up on is when Prism come in, are they looking just at the NHS bit of it, or are they looking across the system in terms of the councils and the third sector, or what's their scope, I guess, is that first question. The second question I've got is there an element of focus of time that is required from any part of the team here to make sure they get full access, so it's just getting people's endorsement that that's happening? I guess it's a yes, but just would like that. And the final one is, when will their report come back? I guess this can't wait until the September board meeting, and therefore could you just share with us what the mandate you need from us, or what's the process that you want to go through to get to what next?
Okay, thank you. Thank you, Chair. So I'll start with Prism's work. So I contacted Kate Connelly, Steve Williamson and Debbie Richards a few weeks ago to ask if they would be happy for a team of people to come in and to look at what we're doing from a no borders perspective, so that we are all happy to allow people to come and see what we do and how we do it. And that will, of course, include how we work with the third sector and how our ambulance service uses alternatives to conveyance into NHS institutions. All of our chief execs have said that they're happy for that to happen. That is unusual. I have never worked somewhere where people would have said, yes, we're happy for, I use the phrase right to roam, as we have lots of ramblers in Cornwall. So we will have a team that will come and look at what we do and how we do it. The time and resource that's attached to that, then each organisation has identified a point of contact for PRISM in the first instance, and we've also set up almost like a librarian function. So the previous diagnostics that have been done for Cornwall, we can bring all of them together, because there is something in us asking the same questions over and over again. We were probably going to find that some of our solutions are quite tricky, which is why we haven't managed to implement them yet. And in 6 weeks' time, they will give us the original diagnostic. Now, we've then got a break point in the contract, because I want to know, as part of the process, do they find our superstars? Where are our people, our indefatigably bouncy people who are going to make sure we do the tricky things, and we're going to back them to make sure that we unblock pathways across Cornwall. And one of the things that is going to come up as part of that is risk, that Margaret mentioned, and also that Rachel made an aside to. So we manage risk in a strange way in Cornwall, that being in a bed in an institution is the least risky outcome for lots of our vulnerable people. But we know there's loads of international data that says if you put somebody in a bed for too long, they won't be walking again. So we need to look at how we manage risk. And just this week, Humans of the Peninsula, that is a sort of a spin-out company that from Disability Cornwall that came into being during COVID, have got personal assistants that we can use for domiciliary care, and we have spare personal assistants. So as our ambulance provider, we're going to make sure that they're on the directory of services, so when crews go to houses. So we need to connect people to each other, and some of that will lend itself well, Martin, to a trajectory in a plan. But crudely, within 6 weeks, we've been told that we need to not have an ambulance queue, because the risk for people at home, and going back to Debbie's point around parity of esteem and people with a mental health problem, having a mental health condition doesn't mean to say you won't have a gallbladder problem, or you won't have cancer, or you won't have a respiratory problem. In fact, it probably says you're more likely to have all of those things, and people will be waiting for an ambulance. So we need to get rid of the queue. So within 6 weeks, John, we will have to have a plan for that. So we can do a between meeting report for the board. And then when we meet in September, we will be at the ends of the 100-day challenge that is referenced in Stephen Marrie's letter. And the 100-day challenge is around us having a sustainable way of supporting our people in Cornwall from both a preventative aspect, who's going to get poorly, and making sure we look after people well who can go home with support.
Okay, so that might work well in terms of the September board meeting. Is that what we're saying?
So it could work well in terms of the September board meeting for the 100-day challenge. It could be that board members would like an update 4 weeks after this meeting as to where we've got with the diagnostics and immediate plans that we'll be putting in place behind it.
Yes, please. Thank you very much. So just to be really clear in my own mind, so everyone from primary care, secondary care, care homes,
voluntary sector, absolutely.
Thank you. And thank you. Anything else from your chief executive update?
I don't think so, no.
And just before, as a segue between that and the True North event, while we're on the subject of risk, it was very interesting to sort of share with you. One of the senior GPs who came to the True North event actually dropped me a line afterwards to actually talk about shared risk. And on the basis that, wouldn't it be nice to actually have risk at all parts of the touch points at the same, rather than this group carry all the risk and this group have a different type of risk profile. There's something also about joining up our risk across our entire system. Okay, thank you, everyone. So shall we move on from the Chief Exec's report? Just conscious of time. So, Kate, please introduce True North.
Thank you. So we had an event on the 28th and 29th of July that we called the True North event. And the True North is like the North Star. So what's our guiding light in Cornwall? What's the thing that is so compelling that we're going to do that will bind us together over the coming weeks, months and years? We invited 75 people from across Cornwall, and we didn't have a centralised invitation list. We asked our people who work in different places around Cornwall to tell us who should be in the room. So we had a mixture of people from lots of different organisations and people who don't represent represent an organisation are people who live in Cornwall and wanted to have their voice in the room. It was a really exciting, high energy couple of days, and the really good thing about it was some of our people who don't represent organisations and came along to see what we were up to left saying it feels like for the first time you actually mean you're going to do something, because we had people sitting together sorting out plans on a geographical basis across Cornwall that were based on the needs of the people that they serve rather than the ambitions of organisations. So attached to papers today is a brief report around the True North, and also there's some slides that we'll be sending out with the minutes from this meeting that go into the detail of the discussion in the session. But just because I want to pull together the discussion that we've just had, what came out of the two-day event was that we agreed our collective vision, which is the same as the council's plan for Cornwall, that Cornwall should be a great place to be born, a great place to live, and a great place to grow old. That together our collective aim is to have connected, healthy, caring communities for one and all. And one of our absolute benefits in Cornwall is we still have natural communities who live and work together. And if we could manage to put support in the place that people live, we might even have a workforce who didn't have to travel, which given cost of living increases and fuel prices, walking to work might be something that lots of people want to do. We recognise the purpose of the ICS nationally is to improve outcomes of health for our population. And going back to Rachel's point, tackling inequality in outcomes, experience and access. And some of that's identifying who is most at risk of developing a long-term condition rather than treating the long-term condition once it's been manifest. Enhancing productivity and value for money. And that's important because that's not cost cutting. That's making sure that the money that we've got in Cornwall is spent well and it's spent on people who need it the most. And helping the NHS to support social and economic development. So one of the things we know about jobs is that when people are in full-time employment, often their health increases because they have access to a whole range of supportive services that they don't have when they're not in employment or in multiple low-paid employments over months. So we are starting to look at how the public sector broadly, the NHS specifically, can look at employment across our county. We've agreed 5 priority work programmes, and this spans across Cornwall. This is healthcare, voluntary sector, mental health, learning disability, neurodiversity, and physical health. So the person at the centre of everything. So everything is about you, your family, your community. My place, so where you live and where you call home, will be part of creating transdisciplinary teams that work together for our people, and it starts and ends with the person or the citizen. A financial strategy for channel shift. So we know from successful places around the world, those parts of the world that spend more money on out of hospital care than in hospital care have better outcomes for their population. And we need to have a strategy over the next few years that start to move money into our third sector organisations, to those 5,729 organisations that already know where our vulnerable people are, who aren't hard to find. It depends who does the finding. And that we base all of this around population health management. We have lots of data. We know who our people are who are going to get poorly in 18 months' time. So the challenge to ourselves as an ICB is how do we find them and support them so they don't get poorly? How do we support their families so that outcomes for those families are better? And that builds us back to employment, building and retaining a health and care workforce that's based in the communities that it serves, and allows people to access training and development in ways that they want to. So the outcome of the True North event was a very bound together community in Cornwall, based in place, determined to be better than we have been up until this point and to address the problems that we've got.
Thank you. Any questions? No? Good. So let's just turn to the recommendations that the first one is that we adopt the vision and particularly the aim that was developed across the 2 days of True North. Yeah, I think it was pretty inspirational that we got to that point. So thank you. We'll adopt that. Thank you so much. To note this, but can I also ask Carolyn, from your perspective, in terms of the comms of the event, how does the rest of it get communicated out about this now? Because 75 people knowing about it is fantastic, but it'd be quite nice to think about how we share that. So I don't know whether you or Kate want to take that up.
So the press release is due to go out, and most people, when they read the press release, will probably think yes, and I think the next conversation is in place. So one of the things we have committed to, if we remember, is if it's a once for Cornwall solution, it's probably wrong. So we need to be talking to Andy and to John and to Rob White around how the integrated care areas and the places where people live, how we then develop the narrative there. So I think that's our next step.
Yeah, and I think we all use our network. So you've got through yours, but also the 5,729 third sector. Also, there must be something. Let's start to use and leverage the contacts that we've got and let them work for us in terms of communicating and then back to us as well. Okay, happy?
Perfect.
Lovely. Thank you very much. Anything else on this? If not, those are the recommendations. Have I missed any? No? Done. Thank you. That's just for you.
Thank you.
Thank you. So let's move on to the quality report. Now, I think that's Susan. Susan, can I invite you? Are you on the call, Susan?
Morning, Chair. I am afraid I'm away from everybody. I've finally got, after day 12, my first negative COVID test, so I'm delighted, but not with you in person, unfortunately. The quality report in front of everybody I will take as read. However, I would like to say, Chair, that as we transition from the quality reports with CCG into the ICB, the format of this report will change. We know that the quality report focuses very much on retrospective data. I would like to bring in, and much of what Kate has already highlighted, and yourself, some of the prospective actions. It's the and so what in answer to what our quality reports are showing us. As we know, the quality assurance is sought through the monthly quality assurance meeting and the safeguarding meeting, plus a whole myriad of other meetings that we engage with our providers, which we will bring together into a succinct report. I'm happy to take any questions, but aware that I'm week 3 in, of which I've had a week off already with COVID, but happy to take any questions from anybody.
Thank you, Susan. I hope you're feeling better too. So that's what we're going to do in terms of, you've read the report, everyone. I've got some observations, but would anybody like to go first? Yes, Debbie.
Yeah, so thank you, Susan, for the report. And I absolutely recognise this is a transition report, but it is nevertheless in the public domain. So I would like to note that I'm not sure it's necessarily helpful to have mental health, learning disabilities and autism, and then referral to child death overview panel reports, because there may be an unfortunate inference. So I would like that to be noted. I think it would be easier in the public domain for that to be children and young people's heading, so there is no inference. And the second thing is that I was also really interested to see the risks, and could I ask what our approach to refreshing the risk register will be for the.
What I'm going to do is I'll come back to that, but let's deal with Martin. You wanted to go first, please.
Yes, I mean, it's been covered a bit, but I just wanted to really thank you for the opportunity to sort of submit to the changing of the reports. And I think, you know, one thing as a board going forward, it'd be really nice to get into the routine of having short reports. This is great. We've seen them so far. Key issues, you know, so by exception, which we're already starting to do, but also, as you said, Sue, that thing about the and so what. So I'd really like to see when we get these reports up and running properly, you know, here are the 5 key issues. Here are the actions we're going to take over the next, whatever the timescale is, month or 2, and then we can come back, you know, at the subsequent meeting to say, great, and the report back is, you know, it's now been resolved because that action has been taken, whatever. So yeah, the bit about the forwards planning is what we're going to lack and what we're going to hopefully introduce for me. So thank you very much for that.
Say that again, sorry, John.
Vanessa?
Thank you, thanks. I welcome the report. I think it's really neat, and coming from the ambulance service, you'd expect me to stop on the piece that talks about the ambulance service, and so the lost hours that are reported in the section there are pretty dire, aren't they? Very high numbers, but I can tell you that they've deteriorated significantly since your latest figure of 7,962 in May. last week they were up over 9,000 hours lost in 1 week. So it is a very significant concern and a deteriorating picture. And going into the heat wave this weekend, we are really, really concerned about patient safety and welfare, given the delays. You note the reset day in Cornwall on the 11th, and so I was down in Cornwall that day at RCHT talking to our crews outside the hospital, and I have to say that was a really hot day as well. It's not just hot for patients, it's hot for crews. Really very uncomfortable for crews in their heavy uniforms and heavy boots as they are. Very difficult for the vehicles to run aircon, keep the engines running to keep the patients cool with the aircon and so on. So I welcome your focus on SWAST and its performance in this quality report. And I'm just sorry to have to report that actually it's a deteriorating picture. And I think as a system, together, we need to have, or to take the opportunities we've got now that you're a statutory body, to work together on finding where we've got the opportunities to fix this issue, what's driving it, what the levers are, and how we can reduce the impact and improve the experience for patients. Thank you.
Thank you, Vanessa. Thank you. Steve?
Yeah, thank you, John. Thank you, Susan. I welcome the report as well. I mentioned earlier on my view of the importance of clarity of the system-wide aspects, and I note that the CQC urgent and emergency care summary doesn't make reference to the, I think, very significant observations and report back that CQC made about staffing shortages in social care across Cornwall. And I just wondered if you could provide some information about why that wasn't covered. I think what the CQC said was those staff shortages were amongst the highest in England, and they used language of that being a staffing crisis, which resulted in a lack and a reduction in domiciliary care packages and care home capacity, meaning that people couldn't be safely discharged from hospital. And given that some of the other aspects which are significant are identified for other providers, why that wasn't included in the report.
Susan?
I didn't catch your last sentence, Steve. Apologies.
Please.
So what CQC said in the report was that staff shortage in social care across Cornwall, especially nursing staff, are some of the highest in England. This staffing crisis is resulting in a shortage of domiciliary care packages and care home capacity, meaning people cannot safely be discharged from hospital. And clearly there was quite a lot more information, an assessment that CQC undertook about that. And I just was interested as to why we hadn't identified that amongst the other key findings from CQC, really to ensure that our integrated care board have the fullest sight of the challenges, the opportunities and the areas in which we can improve.
Yeah, no, I completely agree. We've got to be absolutely transparent about the information that we give, and we did at the last ICB board, the inaugural board. I know Rachel picked this up as part of the CQC action plan. It is multifaceted, Steve. It's one of the reasons that we've agreed this week to open up the coordination centre. And as I've said, the trying to get these papers correct for boards so that they're succinct but have the right information. Clearly, we've got some more work that we need to do to pick all of this up. And by working closely with your team and CFT and other providers as well to make sure that we pitch the right information on these papers is going to be really important going forward. So it's not that it's a deliberate omission. It's pulling together all of the right information at the right time to give to people. So bear with me, and I'm more than happy to take feedback as we go along to get this absolutely spot on so that we are fully transparent. So thanks for the feedback, Steve. It's really helpful.
Steve, as you asked, thank you, Susan, for that. Steve, as you asked the question about staffing, can I bring in Patrick just to make an observation before we move on?
Yeah, I think if the point is that board be assured that the seriousness of the issues relating to the care workforce are noted, then I just wanted to reassure in the report.
Sorry, you're cutting out there.
Sorry.
Oh, we're looking to Peter. No, I think it's go again, please.
Move it a bit closer.
Moving a bit closer. Is that better, Steve? Yeah, it was really just a simple message to reassure that the risk is very high on the board's awareness relating to care workforce, even if that's not reflected in the report.
Thank you, Andy.
Just a small point. One of the hats that I wear here is the primary care partner, and as I've been briefed, primary care in its totality. And I suppose there's a question to Susan, or more a work for Susan for the future, is how do we use the quality report to encompass the totality of primary care, particularly looking that we will become the statutory commissioners of dentistry, optometry and pharmacy from next year, and how do we mature our systems to identify the quality in them?
I'll give you the chance in a second, Susan, to respond to everybody else. I'll give you the final word on it. Margaret?
Thank you. Because we tend to be looking at the glass being half empty, can I just point out that the MIUs were rated as good? And there were very positive comments from the CQC on the staffing, the care provided. We do have a staffing problem, we all recognise that, but still we retained good for our MIUs. And I think sometimes we can be in the council of despair. So just pointing that out.
Thank you. So, Susan, just a couple of observations from myself, and then I'll ask you to wrap up. I particularly thought that Martin's observations about the so what, the looking forward, is everything that we all would agree to. So the concept of, I know we have to report on quite a lot of these items, but also how you draw attention to this board's top few priorities, I think is going to be the trick in any future reports. But although I think particularly we'll be interested in looking back a bit, I think we're more interested in looking forward. So some of the idea of how those reports come with the what do we expect to do next kind of thing, or what do we do as a result of this? And then we can look to monitor our performance against it. So one of the things that certainly Kate and I have spoken about, again, I know it sounds like September is going to be a huge month, is quite how we start, and I want to emphasise the word start, because I'm sure we won't get it right on day one, is start to actually move to a set of forward plans and reports that actually carry not just the looking back, but the looking forward with the how that we can support everybody on, and everybody knows their bit in the journey and can sign up to that. So, Susan, final comments from your good self.
Thank you, Chair, and I completely agree with you. I think there is so much going on, and we've already had quite a large conversation already about risk, and I don't think we've, as a system, yet landed where we would consider collectively our top 5 risks are, for example, which goes back to the comment, I can't remember who made it, apologies, around the risk register. I'm working through the risk register because we need to be able to pull that from all of our individual organisations' IPRs. We need to taking Andy's point about primary care as well, is how do we get into some of that detail within each of the ICAs through our quality leads to bring that together so that we don't have a report that is so full of detail that it makes it very difficult to understand, but is able to share those very clear points, salient points. The going forward piece, I agree with you, Chair. However, we do have to look back to understand where we need to move forward. We know that crude mortality, for example, in Cornwall is rising, and we can't ignore that. We need to understand what it is that's driving it. So those key performance, those sentinel KPIs are incredibly important. And Kate and I have discussed this, things like skin to needle time for stroke patients, from ambulance to theatre times for fractured neck and femurs. Those are all those performance metrics that drive our mortality. And Vanessa, coming back to Vanessa's points, well, making those points around, just the hot weather, our ambulance service, our ambulance crews stood on the forecourt or in the back of ambulances. Those are the sorts of risks that we need to pick up and make sure that we've got the and so what. So apologies that the report, I think, hits some of the right notes, but we've still got some more work to do given the situation that we're in, and that look forward is incredibly important. But we do need to keep an eye on where we can see through those IPRs. They all tell very compelling stories within each of our organisations where our biggest risks are, and use those collectively.
Carolyn.
Just to assure the board that as part of the governance review that we've commissioned, the board assurance framework and the risk register will be reviewed, and we will be looking to bring some of that back through the September and the October board meetings.
Yes, the October particularly. Thank you. That's very insightful. Trudy, you want to have a word?
Yeah, it was. We have recommenced the system risk register work. So I'm linking with Bernie George and Sean from Royal Cornwall Hospital, Caroline White and Lisa Kelvin from RCHT to kind of start that process off. It would be really helpful if Alison and Vanessa can kind of point me in a direction as to who it would be helpful to include from their organisations. And actually, Mary Anson and I have a conversation after the board meeting this evening to start doing the private providers as well. So it started, and we'll make sure we bring something back in September.
Thank you. So Susan, if I can just make the observation based on your comments there, which I totally get in terms of looking backwards in the history. I guess if you can think about in terms of reports, capture a lot of the history as need be for information. And in any half an hour discussion we've got in a limited time, I would rather we spend 5 minutes on looking backwards and 25 minutes looking forward. So for me, it's all about focusing on the future while recognising the lessons of the past. So that would be my advice and guidance. Yes, Kate.
So one of the things, Susan, that would be helpful, I think, is for C charts, so that we've got the trend over time for how things have been, which allows people to just see it, and then we can update the future. Yeah, so we'll build that into future reports.
And one of the things which I can say, we're talking here because it's the first time we've had a conversation about reports. I'm sure, Simon, you can look forward to a very similar kind of conversation in a second. All right. But there's also something about comparators. And certainly as we get into the committee stages of this, I'm sure each of the committee chairs and their colleagues will want to understand not just how we're doing against our own aspirations, but how we're doing against others in this space, particularly in the Southwest. So I think that's something that which you ought to think about as a challenge which you get to.
So one of the things we do in the Southwest, we just look at us. We need to go out and peer benchmarked parts of the world. They've got a similar population: Cumbria, Lincolnshire, Kent, Gloucester, and then we can do that side by side analysis.
And although I won't give too much away, I'm delighted to sort of say I think I'm getting pretty close to getting one of the key leads in NHS England in terms of transformation to physically come down here and eyeball us this month. So let's hope that might help as well. Okay, so let's get to the recommendations on there. Oh, I'm sorry. Ali, I do apologize.
Yeah, sorry, just a really quick comment, just in relation to the workforce discussions. Yep. I didn't want us to lose sight of the broader workforce as well, such as social workers, public health practitioners, our occupational therapists, our AMPs, and also with that forward-looking lens, Chair, that you've just asked us to have. Just starting some of the analysis of the workforce challenges with the reforms for adult social care, currently indicating we need 55 additional social workers for Cornwall. They don't exist across the UK, so we have to have a really, really challenging workforce strategy about how are we thinking about our future demands for all our services. Thank you.
Okay, so let's move to the board is asked to note the content of the report. I think you've asked more challenges that you need to, so I think we can note that. And note the IC reports are currently being redesigned, which we've just talked about. So that is anything else anybody wants out of that other than that discussion? No? Done. So thank you. Let's move on. So are you leaving us at this point?
Okay.
No.
Thank you.
Best wishes. Good luck.
Thank you.
Thank you, Kate. So let's move on to the performance report. Simon.
Thank you, Chair. So my comments will be very similar to the quality report. So first of all, take it for read in terms of people who read the content. I would highlight that it is a CCG-based report, so it also is going through the redesign stage that we were talking about in terms of the quality report to look more across organisation performance and how that relates to each other and the delivery of our priorities as a system. So that is underway but isn't reflected in here. And also we're still hit by the challenge of a report that relates to April data, so it's quite dated, so that's something else we're looking at in terms of our regular reporting going forward. But at this stage, I'll say that we're going through the redesign work. We'll be sharing that through committee at the future meetings. I've got nothing else to highlight, but happy to take questions.
Oh, thank you.
But I was waving goodbye.
Oh, okay. Any other questions? Sanj, might I invite you to share some thoughts on this and where we're going?
Thanks, Chair. I think just echoing what Simon has said, we're looking to use August and also the first Finance Performance Commission Committee meeting on the 26th or 28th, I've forgotten, but using that time to really think through not just what goes in this report, but also how we best use the 3.5 hours of the meeting to provide meaningful updates in the room and then bring them to this board. The challenge we're going to have is structuring the performance reporting both around the ICB itself, as has been pointed out in the 1st of July meeting, but also the wider system and integrating it really around the critical priority areas that this group have identified, and provide also that sort of forward look. And Simon's quite right, this report is quite backward looking. It reflects on CCG reporting going forward, and by September we expect to give you a sense of direction in terms of where we are, of course, but also where do we see the trend going and what actions are needed to get there, and then report consistently forward looking 3 to 6 months out on that. It's also the case that outside of the designated priority areas, there will be hot button areas that come up. And obviously at the moment, flow is of particular concern. I know also there might be other areas such as cancer care and things that do come in. And we'd be really interested to hear from anyone who's interested in seeing that discussed in more detail, of course, committee members themselves. And then really, when we bring this report to the board, we want to give you something that most areas of concern are addressed in the written form, and we can really use the time where Simon and I are presenting what was discussed at the committee as a discussion around questions not covered in the report, so make best use of time. We hope this format will be something that's taken up, but there will be a bit of testing and adjusting, starting with a stronger forward-looking report in September.
Thank you.
I'm sorry, Debbie, I missed Steve. Sorry, Steve, you've been waiting patiently. I apologise. Sorry, Debbie.
That's absolutely fine. Thank you. And Sergeant Simon, I'm really grateful to hear both of those updates, that but both in respect of moving to a forward look, but also moving to a system-wide performance report. As Simon said, what we have is, I think, the standard CCG-based reporting mechanism. I'm sure there are national performance requirements around that, but to have that set of key performance data across the health and care integrated care system from next meeting would be fantastic to see. So I'm very grateful for that.
I apologise, Debbie, over to you.
Yeah, so I had 2 questions. So first question is quite specifically around the new SOF, one of those lovely acronyms that's come out. Do we expect anything materially different to be reported? And then given that to date, we have tended to focus at system level across the country through SOF on largely acute targets, how do we ensure that we are giving transparency across the board in terms of things that matter to the people of Cornwall and the Isles of Scilly, albeit that we don't want to continually add? And what's the unique role of the ICB in presenting this information that picks up on the intersectionality? So when we're talking about elective recovery waiting lists, how are we assuring ourselves as a board that we're addressing health inequalities through that? How do we ensure that we are looking at this through different lenses from the outset? Because that was one of the unique underpinning factors of an ICB.
Thank you. I'll pick that. Yeah, in terms of the system oversight framework, we are expecting some changes to come through, but we're not clear about what they are yet. They're imminent, as they often are. So I hope to bring an update to the.
Could I possibly answer that?
Of course you can.
Is that all right?
Yeah.
Thank you. Just to pick up your point about the SOF, Debbie, actually we had the guidance tail end of last week. Okay, there's 63 metrics that we're going to have to report on as a system. Colleagues have been having a quick look through them. There are a few that we don't currently report on, so we are going to have to look at how we are going to be able to access that data. I touch on the SOF in the strategy paper later, but the metrics for the system oversight framework that we're going to be looked at are going to form part of that segmentation process. However, we've had assurance just recently from regional colleagues that
we will not just be marked on those metrics as part of that segmentation process. They will look and consider the local knowledge, the plans that are in place, etc., to then kind of look at where we will move, which area we'll move into from a segmentation perspective. However, those 63 metrics that we've got to report on, we do report on a lot of them already, but as I say, we have identified probably about a dozen that we either need to strengthen our reporting on, or we do not report on them currently. However, we've also been told that there will be a single database that NHSE and I will populate a lot of that from. However, I have queried that, bearing in mind that we often have discrepancies with data. So hopefully there will be more information coming out to people probably over the next week around the system oversight framework and how we collectively look at that and work on it together, Debbie.
I must have got to leave, so thank you for the update.
Quick transactional question. Kate made the throwaway comment about more use of SPC charts. I would encourage that. Is that something that would fit within the soft reporting?
Can we move away from the acronyms? Okay. Let's have the discipline, everyone, of calling it out. So what report are you talking about?
So in your performance report, so Kate made the comment in the quality report that we should use more SPC charts. And then she said that to you. Do you think that is something that you could put in your performance report for future ICB?
What, do you want to describe SPC?
So SPC, that's what the chair is coming to.
Yeah,
it's not self-reporting, it's SPC. So statistical process charts. So taking a statistical view of the way that numbers are changing. So my interpretation is that they're currently presented as run charts, not as SPC charts. So SPC give you an idea of the rate of change and the direction of change, and whether that's a positive or a negative change. Is that a helpful intervention? Or
yeah. I mean, I think one of the things that you raise here, which certainly I think the committee needs to take away, and you know, you're the architect of the report, is to find a way of articulating not where we've come from alone, not where we're at the moment, but the trajectory of where we want to get to and the roadmap of how we're going to close it. Yeah. Whatever set of charts do that, I'm over it. But what I really don't want to look for is, with respect, that again. We have to have that because there's 63 of them, which we have to do. But this is my point, which I was making to Susan earlier on. There's something which we have to do with 63, and there's something then about what we focus on here that needs to sort of say, and this is my language. If we had the half-an-hour window to talk about performance here, and it's gone through the 3.5 hours in Sanjay's committee kind of time. I'd like to try and understand, how does this fit into the top 6 priorities that we've got? Else it becomes a little bit scattergun of here's a bunch of KPIs. How does this all have a golden thread back to our 6 priorities? Which ones are we going to focus on that shift the dial in this meeting so we can put our energies into debating support, resources, impact, what's happening, what's not happening to shift the dial, while recognising that we have 63 that we actually have to cover off as well. So I think that was my contribution. Tan, you wanted to contribute.
And going back to those central values, let's remember that we're going to try and be person-centred. So when we go back to that and looking at intersectionality, when we look at equity of outcome, we need to be talking about people, not just conditions, and what are their experiences.
Okay, Rachel, you wanted to comment? Yeah, I saw him. Rachel was next.
Thank you. Yes, sorry, clearly you haven't seen the new SPO. Whatever it is, but public health have an outcomes framework. The adult social care has an outcomes framework, which is also being developed. And in the interim, we might want to just reflect on a couple of key indicators related to those areas, not another 120, but just some of the key areas that would just help the process of the board to be thinking about integrated performance in the future. I'm happy to discuss that with Ali outside.
Thank you. Neil.
So just for assurance going forward, in this paper we have 6 core pillars identified at present, and I realise this is CCG framework. If you take citizen focused, place and community based care is where care is best delivered. There's a not applicable against those at the moment. Can we expect to see a reference to those being picked up as part of the financial?
So just so everyone on the call is clear on that. So There's something here about how are we going to scrutinise when it comes to here, both in the board meeting, but also in the committees, to make sure we're covering off key themes. And I think the point that Neil's really picking up, and I heard you kindly say yes, but I just want to be able to say it. Either having a line that says, yes, it's citizen focused is not the answer for the future. Certainly not having something that says not applicable. Actually having a lot more granularity, because what we want to be able to understand is how are you genuinely now thinking about this performance based on the people and the community. So that's what that was trying to get at. We want you to evidence how you're making this clinically led. So if it's gone through a clinical prioritisation advisory group, it would be nice to know it's been through there or it hasn't. It would be nice to know when it talks about place and community, how you've engaged with the managing directors and the 3 forums that we've got here, and report, are they aligned or not aligned, and what does that mean? In terms of reducing health inequalities, it's very easy to get into each of these KPIs. At some point, we need to have this cross-cutting theme about health inequalities, and are we genuinely focused on that? So it sounds like we're asking you to take a very thick volume and condense into one sheet of A4. Good luck. Okay, because the answer is yes. Yes, Sanj.
Yeah, thanks, Chair. I mean, I totally agree, and that does need to be populated. I think realistically, and perhaps speaking for Simon, I don't think all of this is going to be populated by September. So, for example, on health inequalities, that data isn't there. If you look at all the metrics, it's absolute numbers. It doesn't break it down. That's not good enough, but also that's not something that we're going to produce by September. It's absolutely the goal to get there, though.
100% agree. And when we get to the next part of our meeting, in part 2, we're going to have a discussion around the forward plan. And part of that is about when might win. It might be next year even, but this is the journey we're going on, colleagues. Yeah. Vanessa, I'll come to you. Vanessa. Can't hear you.
Thank you. Thank you. Yes, I hesitate to make a contribution actually because I work for an organisation that has an extremely long performance report as well, and we go around the discussion about how to bring the salient points, the priorities to the top, so that we're not all feeling like we've got to keep all eyes equally across 65 different metrics or whatever. But a little suggestion I'd make is around when you identify the key priorities and metrics that you do want to follow across the whole range of different fields that you're tracking, to create a dashboard that goes into the executive summary, because currently the executive summary in the report is really not a summary of performance. It's telling you about what's constituted the process and the methodology for the report, rather than summarising what the performance is. And I think a dashboard in the executive summary might helpfully draw attention immediately to those blinding areas that you want to track.
Because in part 2 we had exactly that debate agenda. So thank you for that. Did you want to comment, Simon?
No, I was just saying, yeah, I agree totally there. And for me, it'd be the same with the finance report. It's telling the story, isn't it? Because you have to hunt at the moment in the detail for what is all this data telling you, even as it's constructed at the moment with some narrative. So I think the main aim is to get to that point where the key things for our system are at the front in terms of data, and the story in terms of why we are there and what we're doing about it needs to be in there. So absolutely agree, and that is our focus. Thank you.
Okay, so just 2 other observations. One is the way in which the non-exec group have been set up in terms of committees is that the finance team, for example, has some of the team from the quality committee on, and vice versa. So Susan, this is really important that what we have here is aligned quality reports and performance reports on the basis there's no point having one quality report saying it's all going southwards and not good, and then the performance report actually giving a different flavour. So there's got to be some alignment there that you can take into your committees. And the only other thing that, just taking up Carolyn's challenge and reminder to us that there'll be a governance review, we still haven't concluded quite how we work with our provider partners in terms of their committees, because there's absolutely no point the ICB committees doing the work that's being done by the provider. There has to be some element of golden thread. So again, taking sans your great challenge. We're not going to get this right on day one, but our direction of travel is to make sure that we add value to each other and we don't compete. So let's move on to the recommendations. We're asked to note the content of the report around the additional and ask for any additional assurances on indicators. Have we done that to your satisfaction? Are you happy to note? Yeah. And similar to the quality report, we're noting the fact that there's going to be a redesign, and stage one of that we'll see in September. We will. Okay, thank you, everyone. Let's move on. Okay, so let's move to the finance report. Simon again.
Thank you. So the finance report is also brief, and I hope you read it. It's brief for the reason, as per all ICSs across the country, because plans weren't finally agreed until the 20th of June submission. The normal comparison of spend to a budget wasn't available for this particular report and was based on the initial submission and not the position where we've submitted a plan overall as a system that's balanced. So that is being updated and will be available for the Finance and Performance Committee at the end of the month. And that's what the narrative in here tells you. It also underlines the fact as we transition from the CCG, which was a Q1 position, through the final 3 quarters of this year as an ICB, we simply have to show a balanced position for the CCG in terms of its performance. So the available resource to the ICB will be the default of that. And we'll also be clear about that in our reporting over the next 2 weeks. And we'll be going through that at the Finance Performance Committee. So that's clearly understood. We have added into this report also the capital position just for information. And again, we'll be adding detail for future reporting, and that'll also go to the Finance and Performance Committee for the end of this month. So next time you will see a set of numbers. The redesign requirement, as we talked about in terms of the other reports, is both something that clearly tells the story of how we're performing on a financial basis, but also looks more widely about the position by organisation, and that's what I'm wanting to describe better in future. So clearly the CCG would have described it on a commissioning basis. Each organisation in our system has its own challenges, such as CIP delivery, as well as many other areas across their organisations. So what we're looking to do is try and expand the report to make those things really clear, so we get a good feel in terms of the service position for the system rather than just a commissioning view. So that's some of the work that's being undertaken and will be ready to report in September and discussed initially at the Finance Committee at the end of the month. So I've got nothing else to add, Chair. Thank you very much. Happy to take questions. Debbie.
Yeah, thank you, Simon. I'm almost going to smile before I say what I'm going to say, but I'm really looking forward to the future finance report, because as an ICB, we absolutely recognise that our financial envelope is finite. I certainly think that the national team framework of the 4 Rs, one of which is respect, and within respect is respect for the taxpayer and value for money. So how are we as an ICB going to move away from not just reporting on provider spend and how that contributes to the system bottom line? How do we get into that space of saying within our finite resources, are we spending our money on the right things in the right way to support our recovery, our resilience, and tackling health inequalities?
So, and as discussed last time, that's part of the programme budgeting piece, which I've asked colleagues to work up and give me a design of what that would look like and a timescale for producing it. So I'll share that with board colleagues offline within the next couple of weeks in terms of a timeline for producing that. But I'm as enthusiastic as you are to do that, so we can see a really clear picture on different areas of service and how it's spent throughout our organisations. So yeah, be looking to do that. Thank you.
Thank you, Steve. Thank you, Steve.
Yeah, thanks, Simon. Thank you, Debbie. And I think this builds on this, but with a different perspective, Simon. Are we anticipating being able in future reports to have an overall care financial summary in Cornwall and the Isles of Scilly? What we have through the CCG based reports is the NHS health funding allocation, either to providers or through commissioners. So my first question is, are we anticipating being able to provide a system-wide financial position which covers the health and care expenditure? And secondly, but it might be a subset of that first question, do we envisage being able to report that kind of particular aspect of the 33 million S256 funding that was mentioned earlier?
So the first part of that is we are intending to report more widely on the spend across our system, as you described. In the first instance, in terms of September reporting, it's more likely we'll finalise the position across NHS organisations. I've got meetings in with local authority colleagues to work through how we can do a more combined reporting for us as a system. Having said that, there are components, as you know, such as Section 256, where we do have information directly available to us that I would report on at a detailed level, alongside all the other areas you'd expect, like BCF and CHC. So those will come into it quite quickly, but I am keen, as I know the local authority are, to start to share a wider position in terms of how we utilise our funds across the system. Does that answer your question, Steve?
It does. I can see that these things will take time, and this kind of question, I think, is relevant in performance and in safety and quality as well. And we touched on workforce previously. So just as a follow-on, Simon, if this was going to take a number of months to develop that full integrated system-wide position, and I could see that it might take some time, are we able to request of council colleagues that, as in the interim, in the September meeting, from a financial perspective, from a performance perspective, from a safety and quality perspective, even if they're parallel reports, we have some information to ICB that starts to give us that insight?
Okay, so Ali?
I'll certainly take that back and bring what I can with me in September, Steve, if that's okay.
So can I make a suggestion, Steve? Is that if I'm not parking it, I will come back to it. I want to make a general point and then see if we can fast track it to September. So Simon, there's something for me about the discipline in the finance, particularly within the NHS bit, if I can say, but I'm sure we'll broaden this, is that we work on the basis if one part fails, it all fails. And I think, that's something that we've got to sign up to, particularly in the NHS, to make sure that it's not, two elements of the three work and therefore hurrah. It only works if all three work. Is everyone in the NHS colleagues prepared to buy into that? Yeah.
John, yeah. Can I comment, and apologies, I don't in any way disagree with that, but it's a broader position, and the financial ability to deliver, and I speak as the NHS provider partner member, is intrinsically bound up with social care performance. So I don't disagree with what you've just said and proposed, but I think it is also dependent on the social care element. So if we think of the pressures that ambulance service incur purely from a financial perspective, leaving aside the more significant and the more important safety, quality and performance aspects, just the sheer cost of staff being held outside of an emergency department, and you think of the impact on the health providers, given the information that we looked at earlier on, showing the increasing number of social care needs, patients who finish their medical treatment waiting to be discharged, the financial viability of the NHS provider system is actually directly and immediately dependent on the whole system. So I think we need to be clear from my perspective that we are mutually dependent, but also dependent on the wider care position.
Very happy with that. I think I was just trying to make the point until we've got. I can see Paul wants to make a comment in a second, but if I can just do a bit of a download on my notes first. So, Simon, there's something for me about trying to be clear as a system, but particularly with the NHS hat on for a moment, which is what our statutory responsibility at one level is for, is that we could look to move to bringing back quarterly formal reforecasts. Just slightly concerned that we actually get to month 11 only to find out that it hasn't gone as planned because we haven't done reforecasting. So there's something for me about, I'd like you to take away the concept of the discipline of how do we quarterly reforecast. Or I don't mind how you do it, but we just don't end up in year to date plus what was budgeted equals our future stuff. Trying to get at. That's the first point. The second one is.
Can I just say, I personally would never work on that basis anyway. I'd always be reforecasting on a monthly basis because of all the things we're trying to stand the comment.
I guess what I'm trying to get at is that as long as we have something formally here where everyone says that is the new collective reforecast, because we might choose to take, and I'm listening to some of, for example, of Steve's challenges, we might choose as a group to reprioritise some of our funding and move things between organisations or whatever, and and that will require some formality to support the whole. So that's my first point I wanted to make. The second one is actually supporting Steve in terms of health and care, but we do need to give Ali 5 minutes to have arrived and started, and therefore for me, I think we're on a journey of that. But I would hope that by the time we get to certainly October, if not September, I think Ali, if we could look to try and understand. And thank you for pointing out all that 33 million is not actually all aimed at the council in terms of social care, our prevention bits of it and third sector, etc. So we need to get what are the right numbers and how they're all being used. What's the money that's gone, Rachel, for example, towards prevention? How's that being used and invested? And how is the funding that went to the third sector being used and invested? So I think we need, even if we can't nail it, Ali, I think we would like to have a early sight in September. Are you comfortable with that?
I'm really comfortable with that. And I just want to say, Chair, if I can, I really want to work in partnership, really openly and transparently. So I've just seen an email pop in. I've not looked at it yet, but I know that we're giving weekly returns on how that money's being used at the moment from an adult social care perspective. But from a performance perspective in particular, it would be really helpful if, Steve, you could be clear about some of those areas that maybe you want to see, or the ICB, because certainly arriving in post, there's a broad set of data for adult social care. And I know Rachel mentioned earlier the adult social care outcomes framework as well. And I've been specifying some data that I'd like to see as the director as well. So it would be, I'm sure you don't want all of that, and it's in various different dashboards. So if we, I'm in the process at the moment, Steve, of specifying what I want to see on that performance report on a monthly basis. So if there's key things that you'd like to see as well, or anybody else.
Can we go through the offices of Simon so we coordinate it?
Perfect.
And Steve, if you things that you would like to see, and Ali that you want to see, if we push them through to Simon, then we get a coherent picture.
So I've been commissioning mine from my performance team in the council. So that feels a bit odd, but do you want me to come through, Simon, on that because they've got the data?
You as the person who presents the report. So what's your guidance?
No, I think you carry on with your.
Want to send it to you, don't you?
That's right. Yeah, cool. And then we just talk to each other on it. And also have a joint discussion with Tracy Langley on the finance side. I'll organise that. Thank you.
I'd hope that's what I was saying. If I didn't, that's what I meant.
That's perfect.
That's fine.
Thanks.
Okay. And the other thing is, again, when we come to talk about the forward plan in part 2, I would like us to try and get some sense as to when we're going to start talking about 23, 24 and the long-term plan. It would enter April the 1st of next year with everyone knowing their budgets and signing up to them. It's been an interesting challenge. Shall I just leave this year as that and move on? So, Paul, you've been patiently waiting. Sorry, over to you.
Well, mine was only a quick point to answer Steve's really, which was obviously, Steve, we do quarterly finance performance risk reports to council every quarter that are publicly, available, that are on the website, that the members approve, etc., etc. I know we're only a small player, Steve, but I'm sure Cornwall Council do the same as well. And I'm sure what we probably need to do is just look at that annual cycle and see that those reports are available in time for coming to this board as well. And then if they need more detail, I'm sure we can get it for you.
Okay, so Happy with that?
Yes.
Yeah, thank you. So let's move to the recommendations. So apologies, we're running slightly behind schedule now. So the board is asked to note the basis on which the report is done was the way in which the CCG used to do it, and as reported in the first 2 months financial position. Happy with that?
Yes.
Yeah. Thank you. The funding arrangements and impact for the ICP in respect to the accounting period, July to March 23. Happy to.
Yeah, so that's just highlighting the fact that CCG will be balanced in Q1.
You can make that as a note in the minutes, please, Trudy. And the capital position as at month 2, noting.
Yes.
Okay. Anything else? No? Thank you. So just before we break, Trudy, there's an important question, an important point that you wanted to raise.
It is. So we've got some primary care delegation reports that came in late. So Andrew Abbott has joined the call. We just wanted to take the board through those, if that's all right, please.
Andrew, can that wait for our natural break, or do you want to get away?
I'm happy to wait, given you're a few minutes over. That's fine, Chair.
Lovely. In which case, colleagues, it's now 10 past. We said we would give ourselves 10 minutes. Are you happy to come back at 20 past? Lovely. Thank you, colleagues. We'll see you at 20 past sharp. We will start at 20 past. And thank you, Ali. Okay, Andrew, over to you.
Good morning. Thank you, Chair. Good morning, everyone. For those who haven't met me, my name is Andrew Abbott. Can you hear me okay, John?
Yes.
Okay, thank you. My name is Andrew Abbott. I'm Director of Primary Care for Cornwall ICB. And the reason I'm attending today is that you received a paper from me on the 1st of July around the delegation of primary care. And subsequent to that paper, but after the deadline for papers for this meeting, NHS England issued a raft of documentation related to the delegation of primary care. And we wanted to make sure that as a board set of colleagues, you were cited on those documents and any implications within them. So I'll do a quick summary of the papers, our assessment of them, and then I'll pause if there are any questions. So the paper I sent to you on the 1st covered the delegation agreement for primary care commissioning. It focused at this first stage around the delegation of general practice commissioning, but provided within its schedules the foundations for the delegation of community pharmacy, community optometry, and NHS dentistry. In the supporting paper I sent, I highlighted a couple of the changes to the delegation agreement compared with CCG days, most notably the liability that now sits with ICBs as opposed to NHS England nationally, the fact that we have the ability to flex the funding both within and outside of the core GP contracts, but also I identified some potential rules relating to the permissions for onward delegation of delegated functions. So since then, and at the end of last week, NHS England sent us a number of documents, which I'll quickly give you a verbal overview now. The first was a memorandum of understanding that is an executive document for us to sign with our NHS England colleagues, which describes the ways of working, principles, beliefs, values, and how we'll try and work as a team of teams with one another. And that was very welcome. Supporting that MOU are some revised terms of reference for 2 meetings that are NHS England direct commissioning decision-making bodies. So those are the direct commissioning senior leadership team, and that's where the directors within NHS England regionally make decisions around their direct commissioning functions. So within this scope, that's pharmacy, optom and dental. And they have revised the terms of reference to invite an ICB executive onto that meeting where there are decisions being made around pharmacy, optom or dental, which impact Cornwall, the Isles of Scilly. And for that, we submitted Rachel O'Connor with me as our acting deputy as Director of Primary Care. Supporting that meeting is an operational group. And I've put myself forward as the prime on that, supported by my deputy, Kirsty Lewis. So that assures you that we're hooked into NHS England's decision-making processes when they're making decisions over this interim year, which impact Cornwall, the Isles of Scilly. The other 2 documents are slightly more legal. One is the data sharing agreement that was referenced in the delegation agreement. That data sharing agreement has been reviewed by our information governance lead, our data protection officer, as being fit for purpose and sound. The only thing we have gone back to NHS England to ask for is a copy of the data protection impact assessment that they have done, and we're still awaiting that. And then the final document was a contractual notice. So within the delegation agreement, it had a catch-all that any subsequently published contractual notices also need to be complied with within this delegation agreement, and we've received our first one. That contractual notice, I'm pleased to say, only confirmed the rules and regulations around the onward delegation of delegated functions. I can cover those specifically. There are 4 or 5 lines if you want, but I'm pleased to say and hopefully provide you assurance that the rules are no different to those that I covered in my covering paper on the 1st of July. And therefore, this is for assurance and for information verbally from me, because I didn't have timing to put it in with the papers, just to let you know, subsequent documents have come through from NHS England that, as we expected, they've been reviewed and they're fit for purpose. We'll await the data protection impact assessment, and the contractual notice that we've signed is exactly as we expect it to be. So apologies that you've had that verbally from me. I've had apologies from NHS England that this has all arrived rather late and after the first date, which is frustrating but understandable. And I'll pause now, John, to see if there are any questions from anyone on the board.
Expected item, colleagues, so apologies for that, and it's going to delay us slightly, but there we go. I guess we can do nothing more than note that, as we haven't seen this physically. So are you happy, based on Andrew, to note Andrew's update? Andrew and Trudy, is there anything more than us noting it that you want from us?
Not from me at this stage, Chair. And what I might suggest is I document this formally, and then we can take it through our first primary care commissioning committee, and then it can be part of the sort of ratified process. So there's a documented audit trail as well as my verbal one.
Lovely. So thank you for that suggestion. So Neil, are you happy if we delegate this down to you?
Yes.
Yeah. Everybody happy with that?
Yeah.
Lovely. Good process. Thank you very much. Well done, Andrew, and thank you.
Thank you, colleagues.
Lovely. Take care. Have a good one. Okay, so we're back on track. So, Simon, the system operator, is it Simon or is it Carolyn who's going to?
So I'm going to lead if that's okay, Chair. So thank you, Chair. Paper with regards to our system operating plan for 22-23. Again, taking it that colleagues have read this, there should be nothing in here that is a surprise to anybody. This is simply a summary of our operating plan that went in on 20th of June to NHS England, detailing obviously our aligned operational priorities, covering those over. The one thing I would just say is that we've heard it from Kate earlier, and you did hear from Rachel O'Connor at the inaugural board about the fact that we'll be pulling these all together, obviously with the CQC actions, the task force actions, trying to pull them together into a single plan, because they are all clearly interdependent and interlinked. And rather than having multiple plans, we're really clear that we kind of want to have one plan, and again that links into the 100-day plan that NHSE and I are requiring. So this paper is just the overview once again to refresh people's memories of the system operating plan, what was aligned within it, and as I said, there should be nothing in here that colleagues have not seen before. Okay. And that's really it, Chair. Thank you.
Thank you. Rachel.
Thank you, and Carolyn, yes, so totally support the content of the paper. I think my point was just to raise with the board that the paper outlines 7 priorities, and I think quite often when we're in discussions with colleagues, we mention 5, or we might mention 6 sometimes, and so I thought it might be just worth clarifying how we would like to refer to the 7, so that we've got a consistency in our communication. Clearly, I think that in other presentations it's been 5 with 2 cross-cutting, which would include workforce and the population, health and inequalities, but where you just say 5, it sort of dismisses the others. So I think it would just be helpful to agree between us how we refer to those as the paper. Thank you.
Thank you, Rachel. So we've always had 6, haven't we? So we've always had the 6 priorities, which were the flow, the elective recovery, the intermediate care, the dementia, mental health, learning disabilities and autism, and the workforce. Population health was always going to be kind of a standalone 12-month programme. But I do feel that because population health management and the reducing the inequalities is woven through everything that we're doing, I think the collective agreement has been that we would count it as our 7th priority.
Yeah, the reason, funny enough, this is why I dropped you a note yesterday actually about was it 7 or 6, because we also need to know who the SROs are for these things, and if you're going to have a 7th, you need an SRO for it, whereas if it's embedded in all 6.
So Rachel is our SRO. She always has been.
Okay, so I guess what I'm trying to get at is that if it's going to be embedded in all the 6, it needs to be written into the 6. Mm-hmm. Or do we now, taking Rachel's point, do we have 6 priorities or 7? I don't mind what it is. We need to be consistent in the language.
Noted. So we had six system priorities with population health management and reducing inequalities as a programme sitting alongside all of those.
Still 6 priorities.
Yes. So
Rachel,
I will make sure that this is corrected.
Lovely.
That
Thank
is
you,
the same.
Rachel.
Thank you.
Rachel.
Thanks. I mean, I might have a slightly different view around that, and I have expressed this at system executive groups in the past, that whereby you have a cross-cutting group but with no resource allocation in addition or a focus, that in my experience in working in Cornwall the last 6-7 years, that has been the case, that this has dropped off. And as one of the core 4 purposes of the ICB and then the discussion later with the ICP, I do feel like we should have it as a 7th priority, understanding that it would be woven through, but that is not sidelined by being referred to or dismissed or dropped from the list, which I know colleagues are committed to from all the conversations that we've had. But I feel it's an important point to make as Director of Public Health for the populations across Cornwall and the Isles of Scilly.
Yeah, and if I can therefore ask the executive group to take that away, but just remind us all of Neil's intervention earlier on in terms of the 6 pillars of scrutiny, because population or health inequalities was one of those. So however you frame it, let's just be consistent. So if you could take that away as an executive group and come back and tell us.
Will do, Chair. Thank you.
And therefore it'll be one or the other, Rachel. Thank you for that. Steve.
Yeah, thank you, John. Thank you, Carol. And it wasn't on that point. The paper's very clear, and I'm grateful for it as a summary of the priorities and the actions. I think it would be appropriate, though, for the boards to recognise 2 areas of what I would consider to be very significant risk. The first is around the urgent and emergency care. And we look at the expectations there of no one waiting more than 12 hours in emergency department, ambulance handover delays reduced and ambulance response times improved. The ambulance response times are under extraordinary pressure currently. If we look at yesterday as an example, the Category 2 mean response time was just under 2.5 hours against a target of 18 minutes. I think we should, as a board, have no misunderstanding of the scale of improvement necessary to be able to achieve that performance. And at the moment, that performance is not improving. And I outlined earlier on one of the determining factors around that, which is bed availability in RCHT. So I think that urgent and emergency care ability is an extraordinary risk, and I think at the moment I wouldn't see that we've got sufficient evidence of traction in the range of actions that are underway for that to translate into being able to achieve those outcomes at this point. So that remains a very significant area of risk. The second area of, I think, very significant risk I would see is the ability of the system to achieve 104% of pre-pandemic planned activity levels. And as an aside, the reality is that the requirement is about 108% because of some contractual and funding changes nationally around follow-up outpatient activity. But regardless whether it's 104% or 108%, I think almost all parts of the NHS are facing an exceptional challenge in being able to achieve that. And I think it would be important for us to recognise that area of significant risk as well.
I'm happy to acknowledge that risk. Obviously, that's part of the work that Kate spoke about earlier, how we pull all of that together to mitigate that.
And just leaning on that point for when Kate and I and you and others will talk about the September board meeting, I think the danger is we have board meetings going forward that touch on lots and don't have material debate and decisions on key things. Can we make sure that we have enough time allotted in September to come back to what is the number one ticket item, which Steve's been raising on that, and give it real quality time to have gone, where are we at? Yes. And what have we done? Has it worked? And if not, what are we going to do? And really, Steve, make sure we focus on September as not just a review date, but one of celebrating and moving on. Sanj?
Yeah, just I totally agree with Steve's point. I think the other thing to bear in mind is looking at past year trends. This is about getting this number down, not in our best month, but in our worst month. And I think particularly with the summer and tourism, we're likely to see this problem exacerbated further. So it is disturbing to say that we're far off the target now, let alone when things are going to be at their worst, or at Christmas or in the summer. I think also it reflects on Steve's point on traction. Having sufficient traction is exactly the sort of thing where we need to look at from a performance perspective on the forward reporting is, are we confident that we have invested enough traction to see a reduction, and therefore confident forecasting of 6 months forward that this is going to be less, if not no longer a problem? So very prescient for Steve to say that. I think some work to be done for September.
And I think the thing is, having a plan is quite different to believing in it. And I think we need enough assurance when we come in September that whatever is put forward comes with enough assurance that it isn't just an aspiration, but it's achievable. Because if not, it's just a wish list. Okay, Vanessa.
Thank you. Yes, I'd like to echo Steve's point, and I'm glad to see it reinforced in the discussion that's around the table. And the point about traction on the plans is a very well made point, because looking at this report, it strikes me that the emphasis on those plans is around alternative pathways to emergency department. And of course, there is more that can be done there. But already in Cornwall, the ambulance service produces the lowest conveyance rates to the emergency department in the country. Southwest Ambulance Service is known for the lowest conveyance rate in the country, but even within that, Cornwall has significantly lower rates than our average across the Southwest. So I actually think there is only at the level of marginal gain around the alternative pathways to ED at the moment. Of course, there's more that can be done for sure, but actually, I think there needs to be a greater emphasis on other parts of the pathway to find the solution to the flow along the urgent and emergency care pathway. And I think we need to spend more time really taking on board what it means when Steve says the number of patients who are still occupying hospital beds who are medically fit for discharge. I think we need a lot more focus on that part of the pathway. Thank you.
Lovely. Mary. I can't hear you, Mary.
Apologies. Thank you very much, John, and thanks for what's being said, Vanessa. My worry with bringing something back in September is that's 8 weeks away, 7 or 8 weeks away. And what we've got is a situation that's been deteriorating since January, despite everybody's best efforts. And we can't really wait till September. We just have to get some traction somewhere on this. I think Steve said earlier, or perhaps it was you, Kate, apologies, people are deteriorating in the trust, and as well as the people who are having poor outcomes because of not being treated quickly. So I think it's just a plea that we recognise as a board that this is an absolutely current situation. We listened to Vanessa say how much worse it's got in the last short period. And I think the other thing to say is it isn't just the number of beds in RCHT, it is the CFT issues as well. And so I'm really trying hard not to make any plea for RCHT, but to say as a board, can we recognise this is a daily situation which is deteriorating?
For sure, Mary, and I'm hoping what Kate said earlier on in terms of PRISM and the piece of work, which is why I asked her about was September going to be acceptable, is recognising that piece of work will be hugely informative which is why I specifically asked, was it covering off the third sector and GPs and care homes and everything else? Because if not, we'll have the aspiration to want to shift the dial, but we won't have the levers in place. Debbie?
So apologies. I think I'm coming through. I think if Kate were here, I think she would remind us all that as a system, we've been asked to sign up to the 100-day challenge.
Yeah.
And therefore, the 100-day challenge is going to be really focused on delivering against that. Yep. So I know I'm here as the mental health
that's
rep,
fine.
but I do think that there is our opportunity to focus on this day in, day out, hour in, hour out is through the 100-day challenge. And we heard already that we now have Helen Skinner leading our system response based at New County Hall, looking at how we can tackle this, John.
Thank you so much for that intervention. Susan.
At the rate of not wanting to repeat, Debbie's pretty much taken what I was going to say. We do need to remind ourselves, whilst we're talking about a report in September, we've got the system oversight meeting next week. We've got the 100-day challenge with those 10 key actions, which we're well versed in, Chair, because we were one of the 14 trusts and one of the 12 social care systems that were involved in the national work. So we are aware of what it is that's required. So we have that meeting, we've got the 100-day challenge. My plea would be to everybody, as my colleague Helen has started the coordination centre at County Hall, is that as providers and as system colleagues, we all join up to that. It can't be a coordination centre that we opt in and out of, because that's the only way we're going to get these actions. And as my colleagues have pointed out, we can't wait till September, and that's certainly not what we're doing. But we do need to get the traction today. It's not just about what happens tomorrow. So we have got the 100-day challenge, we have got PRISM, and we have got the oversight meeting next week, and we've got the coordination centre. So my plea is that we all support that coordination centre and send those folk that can make decisions and make quick decisions there and then. Thank you, Chair.
Thank you, Susan. No, thank you. And that again was part of the challenge which I was hoping to throw out when I spoke to Kate earlier when she was here about making sure that everyone was going to send not just people but their decision makers to these meetings as well. And I think we got sign up to that, Karen.
So taking everything that everybody has said, without going to the recommendations, but that is part of one of the recommendations is actually all of the things that we're currently going to do over the next kind of 6 to 8 weeks, and then bringing a plan obviously back to September that articulates through to April.
Okay, so let's just think now. Nothing else anyone wants to raise on this other than let's get the recommendations, which is to note the content. I think we've added some challenge there.
I think we've focused on the urgent and emergency care element, but we didn't talk about any of the other elements of the operating plan.
Doing it by exception. I wasn't planning on you going through each one. It was by exception. If anyone wants to raise by exception, go for it.
So I think for exception,
yeah,
at the moment, this still feels like a CCG operating plan. And I would like to throw the challenge back in that we mustn't lose the opportunity for the intersectionality here. So there are people with mental health conditions, learning disability, autism and other groups who will be sitting within the elective recovery programme and threaded throughout. So I'm sorry to be a bit of a crack record today, Chair, but we need to recognise intersectionality. Please.
Noted, thank you. And it's probably easier for me to say this, Debbie. I'd love to think, and correct me if I'm wrong, that every single paper that has come here today has only been written by the executive directors around the table. It's probably been helped by teams that work within them. And those teams haven't heard these sorts of types of debates yet. And they're still possibly locked in how it worked with the new brand across the top. And therefore, we've got to find some way of making sure that not just this group of people, but the senior management underneath them, and that I already sense challenge. And I'd like to just throw out to all members of staff they don't need to be defensive, actually. If you're going to do things differently, that doesn't mean what you're doing is wrong. We just need to be able to sort of say, we need to move on. And sometimes that's an uncomfortable thing to land, but we're going to have a conversation about moving people on from that position as well. So noted about the intersectionality, if I can say it. Fine. So let's move to the second recommendation, which is this bit about receiving the paper in September, recognising that PRISM will come out of that, and we've effectively empowered Kate and the executive group to act more swiftly if they need to be. And the 100-day plan.
All of that.
All that work is
together.
in what this is going to, I'm going to call it the plan of plans, really. But if I could just make a little bit of a plea also, I know this is going over ground we've spoken about, but I do think it's important. Too often, it can be seen that strategies are articulated in the nefarious. And what we need to have is objectives that are smart. They tend to actually be numeric by that, or dates driven, or something, or both. And once you've got objectives, you then have strategies. So I just think when we've got things that are coming back, we need to actually have, when we refer to metrics, particularly as non-execs, I don't think we actually mean the 1,000 KPIs, although that's probably part of it. What we're talking about is what success looks like, so we can define it and scrutinise it. And that's why whatever comes back in the plan of plans has to be more than just an aspiration. It requires some form of roadmap with metrics that can be measured, not just in this board, but as Sanj reminded me earlier on, 3.5 hours of your finance and performance committee. It'll be those 3.5 hours that you'll be scrutinising the work to make sure it's on schedule and planned and on target. And you will be coming back to these kinds of board meetings and taking 10 minutes, I hope, to say, happy it's all on schedule. If it isn't, it'll be more than 10 minutes. Is that a happy theme for us to end? All those actions are noted. Do you think I've missed anything? Okay, we're running slightly behind, but I think those were important points, everyone. I certainly wasn't actually expecting Andrew Abbott's intervention on the other paper, so apologies for that, but that was obviously important. So let's move on to the Integrated Care Partnership. So I probably can rescue some time back here. We're going to have our first meeting of the Integrated Care Partnership on the 28th of July. I think we ought to recognise some fantastic work has gone on between the colleagues, Trudy and colleagues as part of the NHS, but also Leah and colleagues as part of the council's side of it, trying to find a terms of reference that can weave its way between local democratic issues and NHS, more centralist, shall we say, approach to life, has been a gift by having our colleagues working on this. So the terms of reference, I think, has reached a point that's in a good place. I would say that, but having looked at them, I think they're in a good place. If anybody would like to talk about terms of reference before I move on, now would probably a good moment to talk about terms of reference, because that is the weeds that we're going to vote on in a second, or not vote on, but support in a second. But I think it's in a good place. It recognises local democracy. It recognises the long-term plan from the NHS. It recognises, in some ways, the working relationship between the councils, the Health and Wellbeing Board, and the Integrated Care Partnership. I think it allows a lot of flexibility to be able to develop whatever that group of people want to actually see as the Integrated Care Partnership that is then got to be working hand in glove with the councils to think about the relationship then between the Health and Wellbeing Board and the Integrated Care Partnership. So I've got some notes in front of me, which I'll just share with you, because this is sort of live off the press, because there was a conversation between Kate Canally and Kate Shields yesterday in preparation for some of this today to try and get our minds round. Kate Shields has informed me that it has been agreed that Rachel O'Connor and Rachel Rotherow will take the responsibility for driving the Integrated Care Partnership strategy. That we will look to take things like the Better Care Fund, Section 256 and Section 17, is it? Section 27, whatever it is, the 75s, in as part of this, because there's something here about these areas overlap each other. And there's something about that group of people starting to actually look at how that works and flows from the Health and Wellbeing Board strategy, and then how we devise ours. Because one of the challenges, colleagues, coming back to the plan that we're going to have in the plan of plans, Carolyn, is having to recognise that we have to have an integrated care partnership plan agreed by December. As if we didn't need more strategies to have to be agreed. That's one that's been given to us by the Department of Health. So I think there's some great progress being made. I think the terms of reference are pretty clear in terms of its membership and how that's working. And I think it's a true reflection of a council and NHS partnership working with Mario and his colleagues from a Health Watch perspective. And until we know Helen's replacement, Joe, through yourself and the third sector. And I think what with some of the other colleagues who sit on there, I think we've got a good balance where we can talk about some of the higher strategic issues that might actually start to shift the dial. So before I get to any other points on that, Rachel, you wanted to raise a question.
Thank you. No, it was a comment, and in Ali's absence, just to sort of reiterate, really happy with the outcome and the work that was done jointly on developing of this, and also with the Isles of Scilly Council. So fully endorse, the draft that's in front of you, and I know other bodies, including Cornwall Council Cabinet, will be looking at this to approve on the 20th of July as well. So very happy, and thank you for the positive way. And I think that we've all approached this and look forward to the first meeting on the 28th.
Thank you. And for those who aren't aware, the Isles of Scilly, Council for the Isles of Scilly and Cornwall Council have now come together with one Health and Wellbeing Board. They're going to meet twice a year. Kate Shields and I, in our new roles, now sit on that. So there's a representation there as well, as much as colleagues are sitting on our board. So that's sort of joined up bit of it. And that group is going to meet every 2 months. That's the idea at the moment. So, unless there's any questions, I'm going to try and catch up on time and go through some of the recommendations. So, unless Trudy can tell me anything different, I'm not quite sure why I have to be, as chair, considered the ICB's founding member. Trudy, before we do that, is there a particular reason behind that?
It was one of the things, John, that was kind of expected as part of the Health and Care Act, and it will be Linda Taylor, and sorry, I've forgotten the member from Council for the Isles of Scilly. They will also be founder members. That gives you the right to constitute the Integrated Care Partnership.
Okay, thank you. So on our behalf, because taking some of the comment that was made by Rachel there, of course, once we sign this off in this board, that's not the end of it. Cornwall Council are going through their cabinet. I think you said the 20th of July, Rachel, but anyway, and then I know Paul and his colleagues are taking it through the Council for Isles of Scilly before the 28th, and therefore, assuming all three sovereign entities, if I can put it that way, all sign up to it, the time we get to the 28th, we'll have all done our collective part and we will be signed up collectively. So, assuming you're all happy, I will effectively be the ICB chair, considered our ICB's founding member of the Integrated Care Partnership, that we approve the terms of reference, confirming any amendments required. I don't think there are any from what I'm hearing now, and that you give effectively me in my role and Kate in her role delegated authority in the event that minor amendments come out of the discussions with Cornwall Council in their cabinet meeting and the Council for Isles of Scilly in their meeting. If there is any minor amendments, to delegate down to us to make those changes. If there's anything substantive, well, then we'll have to come back to you first. Are you happy to take all those recommendations? Lovely, thank you. So before I move on, Trudy, on this one, because to get this one wrong would be quite a delay factor. Is there anything else you feel I need to cover off here?
No, that's it. Thank you very much, John. I'll let the council know that there's no amendments from the ICB board.
Lovely. Thank you very much. Great work, everyone. Okay. Let's move on to strategy planning timelines. Carolyn.
Thank you, Chair. So colleagues have got a paper which is really for information to basically cite the Integrated Care Board members on the timetable for various pieces of work around the NHS long-term plan, obviously the integrated care strategy, our joint forward plan, the work that we are doing at the moment with the work and health unit, Also a bit about our green plan and climate resilience, and a piece around the NHS oversight framework, which obviously we talked about earlier. So again, taking the assumption that this has been read, as I say, this is really for colleagues to see the pieces of work that we need to complete in the timeframes. We're clear there that obviously NHS England are refreshing the NHS long-term plan. I think we were expecting that next week. That's now been delayed. That will then inform what we then do with our integrated care strategy. And the pieces of work that are listed there are the large pieces of work that we've got to do before March 2023. The bits I kind of would just like to bring to people's attention is that the piece of work with the work and health unit is a very short piece of work, and I was leading that, but as it's around employment, that will move to Patrick. And the green plan piece, we will have a conversation around that later on today. But this, as I say, is really for colleagues to understand the work that we will be doing collectively between now and March 2023.
Any questions? Oh, hang on. So let me just make sure. Sorry, I apologise. Steve.
Yeah, thank you. Just a brief one. I thought it was a really helpful paper, very clear and really useful from a provider perspective. So thank you. It's great. The document, Carolyn, refers to the potential for a memorandum of understanding between NHSE and HICB. I think the oversight framework guidance also mentions the possibility, or it might say requirement, I'm not sure which, of MOUs between ICBs and NHS providers. I just wonder if you could give us any information or context on whether we think that would be required at a point in the future as well.
The system oversight framework is being specifically driven through from NHSE through the ICB, but there is that provision and we are able to look at that. As I said earlier, we've only just had the guidance the kind of tail end of last week, so trying to pull it all together and digest it so that we're able to communicate out to everybody. So we will be looking at that as part of that.
Okay.
Thanks.
Jane?
Thank you, Chair. I suppose I just wanted to say, obviously, we're doing the same piece of work and timelines in Devon. So the intention is to link in with colleagues in Cornwall so that we sort of ensure we've got some alignment. I mean, not suggesting it will perfectly align, but we just want to make sure that we don't have anything that falls between the cracks.
Thank you, Jane.
Neil?
I just ask whether, when we're producing the integrated care strategy, that with citizen focus in mind, we might take advantage of an excellent document that's arrived, guidance on working with people and communities. I think it's a very key document to the way we would want to go on.
Was that circulated to everybody? You've all...
A lot of people. It's come in various routes from various people.
Trudy, would you be kind enough, based on that suggestion by Neil, that document that you forwarded to me, I don't know who it went to, but if you could forward that to everyone, I think it's not only is it an excellent document in terms of citizen focus and communities, but actually it goes to the heart of ICP development as well. Yeah.
There's 10 core principles in
it.
Yeah.
So if you could also then think about who's on the Integrated Care Partnership Board and send it to them as well, because that might become an interesting document for the 28th of July. Thank you. Any other questions? I've got one or two. Okay, so this is a question of clarity on the paper. So the NHS long-term plan is being refreshed.
Yes.
When do you get that final guidance? Is it the end of July?
So it's the end of July.
Yeah, it's the end of July. When you get that, what will that mean for us, do you think? Have you got any sense that it's material, or is it?
So there has been some information that they're going to look at it over 6 Six is a very popular number. I've come to the conclusion. 6 different aims that we would work towards. When we've seen them, they are absolutely across what we're already doing. So I think it won't materially change what we're doing. But what obviously it will do is it will just reframe some of the previous long-term plan work against those new 6 items.
Whatever strategies that we come up with as an ICB one or ICP, we don't want competing ones. So it just gives the assurance that these will have a golden thread of consistency with them. Yeah.
And we do need to remember that although NHS issue the long-term plan, that we do need to make sure that we are addressing the needs of the long-term plan, but that everything that we're doing is meeting the needs of our local residents.
Okay, so when I just thought I got this, I read this document, so I'm clearly the lowest common denominator yet again. What is the difference between the 2 NHS plan, integrated care plan, versus the joint forward plan? What does a joint forward plan hope to achieve that isn't in the other 2?
So this is how they've kind of framed the long-term plan. Will be that kind of overarching document. The ICP will have to look at an integrated care strategy that is 5-year forward view looking. Yep. But the joint forward plan is going to have other guidance, which as it says there is going to be released in autumn, and we've got to incorporate that through that 5-year plan. It's not particularly clear at this moment in time without seeing the long-term plan and the guidance for the joint forward plan, because we have questioned. We've got 2 things here driving a 5-year plan.
I think one of the things, I hope to get your support on this, there's something for me about, I know what we have to do for let's just say government at the moment, keeping its wider sense, because there's a lot of part of government with a small g. But also, if we had to try and articulate a strategy to the person on the street, I'm not sure whatever we're going to write for here is going to land. So the reason why I just wanted to be slightly contentious in this is, can we almost have one that says everyone in Cornwall will get this strategy document, such that it's written in a language, it's simple, it's shorter, and it isn't using all the acronyms and whatever else.
The only thing I would point out is that the joint forward plan is for the ICB.
Yes.
And the integrated care strategy is for the ICP.
Yes. Okay. That actually helps a lot. So if we could call that the ICP joint forward plan, then it'll help me remember. But can you just take my point about whatever we do, can we look to have another draft that is for the person on the street who might get it?
Okay.
Yeah. Yes, Debbie.
So as part of our future ambitions, will we be looking to have easy read documents available?
Just define easy reads.
So easy read is specifically written in plain language as part of transforming care to support people with a learning disability or other communication requirements.
Wouldn't that be a fantastic challenge?
John, it also makes it much easier for everyone to understand.
That's exactly where I was coming from. It becomes the threshold at which you
need expertise. You need expertise to do it.
Do we think this is a good idea? Sam?
Absolutely, and I just wonder, is this perhaps part of the brief of the Engagement and Communications Director to look at, or could it be?
A good challenge. Yeah.
Jim, that was a challenge brought in a meeting I attended by a member of CFT's advisory panel with learning disability. His challenge was, if I can understand things, most people should be able to. And that was brought from someone with a learning disability.
Yeah, Debbie.
Just follow up. So if we have it as a defining principle, then living that through as a value of the ICB, it's all papers. So there would be the statutory finance paper, but then an easy read.
Okay.
Statutory performance paper. And I know that would be work in progress, Chair, but it would be a fantastic principle for us to sign up to as a board.
Let's not just tick this off and yes.
I was just going to say, if any colleagues in partner organisations are already doing it, for their own boards or for their own meetings. It would be really helpful to see an example.
You have one. Do you do it in CFT?
Not as well as I aspire for us to do it, Chair.
Okay,
So,
that's okay.
so it's a challenge.
Could you put somebody in contact with us?
Yeah.
Because I think one of the challenges is even if we've got one paper right and got the model right, rather than try and yeah, go for it.
And just a quick thing, just to check ourselves in those places. You know, when we talk about 104 weeks, actually what that means to real people is 2 years. When we talk about 78 weeks, it's a year and a half. When we talk about 62 days, it's 2 months. And actually, obviously, technically, there are difficulties behind that. But when we're talking with people, that's the way that we need to explain
Good challenge. We're going to take everybody up for that. Let me just go to the colleagues on the call. So, Jane.
Sorry, just going back a step. Although I do completely agree, and that is our ambition as well, to do that in terms of ensuring access to our documents. But just going back a step, we are trying to endeavour and just have one plan. So otherwise, it's just going to get really confusing in terms of the ICP, the joint board.
Challenge for us. Why can't we have one plan? We're going to have one plan, Jane. Thank you for that.
So, there you go.
Thank
I'm
you.
not suggesting it's going to be easy, but that's the ambition. Yeah.
Thank you. Mario.
Yeah, going back to the Easy Read discussion, we put out a lot of our publications in Easy Read. I don't think it would be possible to produce board papers in ICB, board papers in Easy Read. I think logistically that would be too big an ask of the system. But what is important is any communication direct to the public from the ICB is available in formats that are readable.
5 to ensure that any public document actually is on the Easy Read format. But let's maybe just start with board papers actually being able to be read by anybody. That would be a great start, and not turn into a cottage industry of 70 pages is clearly better than 3. Yeah, less is more. Okay, really helpful discussion. So let's just make sure, did I cover off the board recommendations here? I don't think I did. We know the content, so we're happy with that. We note the long-term plan, the joint forward plan, integrated care partnerships will all be part of the forward plan presented to the ICP in September. And we'll map out the critical path for each. And we're going to pick some of this up in part 2, colleagues, when we have a conversation around forward planning. So before we get too excited, hold that thought and we'll pick it up in a short while. Anything else that you want to discuss or get noted? Caroline, are you happy?
Yeah.
Lovely. Let's move on. Thank you very much. Patrick, over to you. Reablement.
Thank you, Chair. So this paper reflects conversations earlier today about workforce and employment, very relevant to that. So it signals an early integrated care commitment to moving at scale on a particular workforce issue relating to apprenticeships around reablement. I will take the paper as read, but a couple of things just to draw out for everyone's attention. So this programme will see 75 apprenticeships from November 2022. And the assistant practitioner roles will focus on the discipline of reablement, which is a clear priority for us as an integrated care system. The paper describes that we're working with South Devon College, who are bringing some innovation in terms of how apprenticeships will be supported, how their learning will happen, big emphasis on field-based, and we're looking to ensure that their work is aligned and supporting ICAs in local reablement provision. CFT are hosting this apprenticeship programme on behalf of the integrated system, and it's a 2-year programme with an option where that's mutually agreed for an extension of further 2 years to degree level qualification. The only other thing I was going to highlight is it's underpinned by apprenticeship levy transfer, where we have got donated levy funds that are enabling us to move at the scale that I'm indicating. As I say, early indication of our ambition. This is looking to take forward our work on reablement. It's here for information. Happy to take any questions that the board have got. And I'll finally just finish with a thank you to Sally Wilson and Helen Wilding in the people team in CFT who have been making the running on the detailed work.
Oh, thanks. Thank you. Tom.
Yeah, this is great progress. This has been something that's taken quite a while to get over the line, but it's a real genuine opportunity to show the benefit of whole system working. Specific thanks to CFT for taking on the employment. That's a really great task. Just one short question for Simon. Just to get a confirmation that the recurrent funding will be budgeted for, the cost of these enablement apprentices will be budgeted for in the future.
It's within our resource planning for recurringly.
Thank you.
Lovely, thank you. Joe.
Just a question for my understanding why South Devon College and not the Cornwall colleges.
The bit that South Devon are bringing is some different approaches in relation to how learners are supported, that bit about field-based and also the assurance around degree level. That's not to say that we wouldn't look to develop similar arrangements with Cornwall's colleges as well.
So if I can help on that is one of the problems with some level 5 type courses is that the learner goes down a cul-de-sac. After 2 years, that curriculum is of no use to them if they want to progress. So what this course will allow them to do is they'll have a segue into it being a 2-year top-up with, say, Plymouth University to be able to go on to be a registered nurse. It means they don't have to go all the way back and start all over again. So this is part of the career planning that might actually attract people into our system because they can actually see a value of their career rather than sort of working in Tesco's or barista. And the second point, which Patrick has touched on, but is absolutely pivotal, most FE colleges, you have to go to their campus. And if you happen to be based in Launceston, it's a fair old journey down to Truro, as an example. So there is quite a strategic leap here where what South Devon will do is they're going to put 3 or 4 nodal points in that should make it no more than half an hour, 40 minutes for any person to actually get to a training hub. And that is quite a different model. So those are 2 of the main thrusts in here. Yeah, Sanj.
Thanks. I think 2 points. One was I noticed November 2022 of a start date. Do we expect this to help contribute to lessening the pressure on flow at the winter rush, or is that something factored in, or is it just coincidence that we're going for a November start? And the second point is really, do we see this as a scalable initiative? Because laudable, but 2 million and 75 is not going to shift the needle by itself. And if so, is there a plan around scale? Are there some sort of metrics we're looking at by which we can say tick box success and we should scale this?
Patrick.
So in terms of November start, I would want just to manage expectations. There will be new capacity coming into the system from November, but these are people who are learning and can support. So there's a balance there. It's not a silver bullet to winter. This programme is not that. There'll be other effort needed. Relating to the scaling issue, I think what the levy transfer part indicates is we might be able to attract greater funding to support increased apprenticeships. This is a signal of a direction that we'd be looking to see in our workforce strategy going forward. And there's a couple of things in here that indicate where we might be able to build for future scale.
And it's definitely not the silver bullet to the problem. However, of those 75, 20% of their time will have to be in learning. By definition, 60 of them can be in the field. And that will allow 20 in the west, 20 in the centre and 20 in the north out to be in the field, not based at a particular geographic location. So it'll be helping social care support, hopefully helping people get out of hospital. And that's one of the themes that's behind here. Mary.
Is this a roll-on signing up, or is it 75 people hoped for on day one?
We're pushing for day one, Mary. We'll obviously be dependent on applications and the success of our recruitment, but we are looking to get a day one approach on this.
Because it is going to help winter. There's no two ways about it. Yeah, no.
I think it's a very positive thing to do. Just a little thing that concerns me listening to Apprenticeship in Cornwall is that my experience through primary care apprenticeship roles we put, that one of the big issues, especially for younger people in Cornwall, is transport into the field and where they need to get to. I notice there's a mentoring element to it. I hope that's something that'll be picked up on quickly, because my experience was that it was a limiting factor for some young people, the ability to get to where they're needed.
We've all had experiences of it. My experience of apprenticeship, though, is that we need to make the mental leap away from 16-year-olds equals apprenticeship. I know you weren't suggesting that. It's quite surprising how you can be in, quite a young adult and actually still wanting to change your career or get into one and that kind of thing. So I'm just hoping that when we get the adverts out, we will be thinking about people who are genuinely wanting to get into a career based here, and we start to build people who will get in and stay in these kind of things. Debbie?
Yeah, I just think more broadly, I really welcome the fact that we now have a system director of workforce and OD, so that we can actually have that strategic discussion here. We've got pockets of apprentices and apprenticeships across the county, and I think there's a lot more we could do strategically working together.
Cool. Delighted. And thank you so much for your interventions. You've been helping making this happen. Without your help, it wouldn't be here now. Shall we move on?
Could I just butt in, John?
Sorry, I thought it was a legacy hand, Mary. Go.
Yeah, I'm just a little bit concerned about the timing, because potentially this could take a number of people out of the existing social care sector to sign up just in time for Christmas.
Of that risk, this could be attractive to people who are currently working for us, and that could create a gap behind, which may be problematic. I think that the paper refers to risks that we'll manage in the delivery of the programme, and we're cited on that one, Mary, and thanks for highlighting it. It is a key thing for us to manage.
So I hope you found, were you aware of the NOMIS report?
I haven't used it in previous sectors.
Okay, fine.
But similar.
Yeah, there's something about the labour market that we need to understand, Mary, and possibly as we go forward, not just for apprentices, but as you're right, Debbie, in terms of having a single workforce lead here, is thinking differently about how we attract people. And it might be about flexibility or all sorts of different things, rather than being maybe a little rigid in some of our thinking. So this is day one. It's not the big answer, but thank you so much for getting us here. So let's get to the recommendations. Where are your recommendations on here? There we go. The board are asked to support the programme, note its progress towards launch of reablement apprentices. Everybody happy to support and give them Town's intervention on the funding? We can minute. Everybody happy? Done. Lovely. Thank you very much. Let's move on. Approval of additional key policies. This is going to be riveting stuff, isn't it? So
I know how to get you going just before lunch.
Dearie me, dearie me. So over to you, Karen.
Thank you, Chair. This actually, I hope, will be quite a quick item. So colleagues be aware that we brought some policies to the inaugural board on the 1st of July. The ICB's policy on policies is going to be our guiding document, and we sought legal review of those 20 policies from solicitors Brown Jacobson. At the inaugural board, we brought some of that feedback to the board and signed off some of those policies. We've now had further feedback from Brown Jacobson on the remainder of those policies, and really I would just like to quickly take the board kind of through that feedback. So in general, the feedback for the remainder was very positive, and also the authors of the documents have confirmed that having fresh eyes reviewing them was really, really helpful. Generally, there's no major amendments needed for 9 of the policies, apart from the whistleblowing and the EPRR policies, which I'll come on to separately. So as I say, good feedback from the others, and no major amendments. There are 2 remaining documents: the decommissioning and disinvestment policy and the engagement strategy, which we'll bring back to future ICB board meetings for consideration. Now, the engagement strategy is because we've obviously out to recruitment for a new director of engagement, but also from our perspective as an ICB and an ICS, we would like to do engagement differently. So our strategy needs to reflect that, and therefore we will need to build on that, working kind of across partners. So those two will come back to a future board. The two I'd just like to bring to your attention really are emergency planning, resilience and response, which is EPRR. The EPR policy had been updated to take the additional responsibilities placed upon the ICBs as their category 1 responder responsibilities. However, NHSE published the revised EPRR framework on the 8th of July. Therefore, Brown Jacobson have reviewed the policy based on what we submitted as part of our transition plans, because we had to put in a policy around EPRR for our transition. So they've reviewed that document, but clearly now we have the new framework information. We'll have to go back and review again, and clearly we can do that alongside the feedback that we got from Brown Jacobson on the original policy. The other one was the whistleblowing policy. So again, it's all about timing. The new National Freedom to Speak Up guidance was issued on the 23rd of June, and this included a new model policy template. So therefore, we're not intending to approve EPRR or that policy today, because there again we are going to have to go back and review our whistleblowing policy based on the new guidance and the new templates. But again, we would look to bring that to a future ICB board. Both of those clearly, as part of their new reviews, would go through their new relevant committees. So that's obviously to be noted. And one of the other things that I just kind of wanted to point out is that once the policies have been ratified and signed off at the Integrated Care Board, then clearly they'll be completely rebranded with the ICB logo. We will put all of the new committee names in and relevant job titles, etc., which have now been agreed. They'll be checked for accessibility standards, so they were checked all the way through, but just going back to some of the points earlier, I think most colleagues have had accessibility training, so should be looking at their documents as they're reviewing them all the time. They will just go back through that, and then once they've been confirmed, they'll be published on the ICB document library. So that was really it from me, Chair. Thank you.
Okay, this is the test who's read the stuff. So oh, sorry, here we go. Mario, you go first.
Thanks, Chair. Thanks, Caroline. On the engagement strategy, a couple of points. One is there was an engagement strategy that was circulated. I got it through my membership of Citizens Advisory Panel. Can you let me know what the status of that is, please? And also accepting that with the appointment of a director for engagement, she or he would obviously need to have a major participation in the production of that strategy, but the appointment has only just begun, so that'll take some time. And my concern is that we put citizens engagement at the start, as the number one, perhaps number one objective, and this is going to be one of the last things to be produced in terms of documentation or strategy for the ICB. And the third point, Chair, and I'll stop, is what will be the involvement of the Citizens Engagement Subcommittee with the production of the strategy? Thank you.
Thank you, Mario. So you have seen a current engagement strategy, because once again we had to put in an engagement strategy as part of our transition from the CCG to the ICB. So we are using that as a very good starter for 10, but there is clearly more work that needs to be done, because we want to look at engagement in a very different way. We need to engage with a lot more people, and I appreciate that the Director of Engagement has only just gone out. However, that doesn't stop us building on kind of what we're already doing, taking some of the learning, taking what we heard from the True North event, taking what we need to do at the integrated care areas and starting to kind of pull all of that together. I would like to think that once the Director of Engagement is appointed, and I appreciate that's maybe 3 months away, a couple of months away, but once they are actually appointed, then I would like to think that they might have some capacity to be able to support remotely while we're beginning to shape it. So I do think there is work to be done that we would be able to get on with to build on the, as I say, the engagement strategy that we've currently got. But bearing in mind that we want to do things very, very differently, putting people at the centre, really being able to go out to people and focus on it. I still think there's work that we could be getting on and doing and engaging with our colleagues to help build that. Does that answer all of your questions, Marion?
Yeah, thanks. But just a point about the Citizens Engagement subcommittee and its role there.
Yeah, so are you talking about the Citizens Advisory Panel?
No, the subcommittee, the one that Carol's leading on, the subcommittee.
Okay, so the Citizen Engagement Committee is going to have a date set for September. Carol unfortunately isn't very well at the moment, but we were due to have a conversation about the committee and how the strategy and how we would engage through there, but obviously that's had to be cancelled. But we will be using that committee to drive forward a lot of this.
If I can help, I think it's important that this isn't in this pack, by the way. This policy pack engagement.
No, it's not.
No, so we're having a conversation about something different, just so we're all clear. I think it's fair to say, Mario, is that the word engagement can mean different things to different people. And I think the current engagement strategy is fit for purpose if what we have is an engagement strategy based on communication. I know you've read the job description. For those who haven't, the specification for the new way of doing engagement is so much more than just communications. It's actually about gaining insight, looking to do end-to-end patient pathways, user experience, touch points, all the sorts of things that means they're having an engagement in the service redesign as opposed to just communicating. So I think that will require us as a group, when we come to talk about the forward plan in a minute, to actually think about quite when it's fit for purpose to have a grown-up conversation about a refresh of that strategy. But if we can just park that for a second, come back to is it 9 policies we've got here? Yeah. The 9 policies, I'd be grateful. Mary.
Yeah, thank you, John, and thanks very much, Carolyn, for this piece of work. I'm just wanting to get real clarity on quite what we mean when we put some responsibilities on the ICB board members who may not be and are not exec directors or non-exec directors of the ICB. So in section 4. Particularly in relation to the grievance and dignity at work and the organisation and service change policy, I'm not sure. I wonder whether it should be clarified that some of those responsibilities are exec and non-exec responsibilities of those members who are ICB rather than those of us, because we have those responsibilities in our own organisations. And maybe it's just a point of clarity.
Trudy, do you have a view from a governance perspective?
Yeah, so I understand where Mari is coming from. However, these are ICB policies, not ICS policies, and this is the kind of the confusion I think that we get into. So in those documents, it refers to responsibilities that sit with ICB execs or people like myself or deputy directors. So I think that hopefully provides Mari with the assurance that she's after. It might be, and this is the one that I reserve judgment on, is when we revisit the EPRR policy, because of the changes to the national framework, there may be things in our policy that then cut across provider policies. So we will need to make sure that we're all joined up and aligned and we're not kind of cutting across each other. So that's why that might take a little bit longer, because we'll be coming out to providers as well to make sure there's appropriate flow and agreement across the system.
So I understand that, Trudy, and I can understand the difficulties. It's just from a purely practical point of view, those of us who are in other organisations can't actually touch on the organisational change responsibilities and the grievance dignity at work policies. So I'm just not sure practically how that would work.
Trudy, does it differ? But I think what you're asking, to the heart of that, Mary, but correct me if I'm wrong, is there's some members of this board who are like Debbie and Steve, who are formal members of this board, who really have to, when they're wearing this hat, by the way, not when Steve and Debbie are wearing their other hats, but we're wearing this hat, there's a certain responsibility. But given the fact that yourself and other colleagues, some of you are participants and attendees, does it apply to them as well, Trudy?
If I recall correctly, we had this discussion at the first board as well to understand what hats, especially the likes of Steve and Debbie, who are voting members, when are they doing this and when are they not? And we agreed that the principle was there are certain things that we will just have to judge and take a pragmatic decision on and kind of work through it, because every item in those policies won't be relevant to those, I'm going to call them non-ICB staff, but there's some principles and ethos that we would like to adopt. So I hope that that helps.
Steve, can you help?
Very helpful question. We did touch on this point of principle about what is the role of the Integrated Care Board, and I think what this is about, it's a really helpful question, is in the context of the staff who are employed by the Integrated Care Board. And at the moment, the policies, as Mary has set out, placed requirements on all ICB board members. Some of us as ICB board members wouldn't have the access to staff in the ICB formal organisation that executive directors and non-executive directors would have. And I wonder whether there is a line, Trudy, that we should have in the overall policy of policies, as an example, which says in relation to staff safety investigations that those sorts of technical matters, they're the remit of the non-executive directors and the executive directors of the ICB. Otherwise, we would need different accesses and different kind of mechanisms to be able to fulfil the requirements, which are quite clear in the policy that places those requirements on individual ICB board members.
Patrick, can you help us? Bear with me, Trudy. Patrick, any thoughts?
Yeah, my understanding is these are the policies that relate to the ICB as an employer, and the membership organisations will have their own and mechanisms for following those through. I think it raises some interesting questions, perhaps for the longer term, about how much our policy content is in common, and we can pick that up. But for the purposes of this item, I think that's this relates to the ICB as an employer.
So I'm going to be now. So if we take the four, I think that may be in the Venn diagram more complicated by that, which is Andy, Debbie, Ali and Steve. They're not technically employees. Or how does that work?
They're not employees of this board or of the ICB.
No. So do these policies apply to them?
Is the point not more about sovereignty of employment?
I'm just asking for clarity, I think, which is Mary's point. Mary?
I think that last point that was just made was helpful. However, I think it is really important we get this right, because having done it, and I'm sure other members of the board have, it's some of these very small points that really matter when it comes to getting into a difficult, for instance, grievance or disciplinary procedure. So I don't know whether we need to take further advice. And you're right, this might be an iterative process, but it's very clear that people who are not employees can't act in these capacities, because they don't have the leverage on employees that we would need to have. So I think it's maybe a small point, but I think we need to get clear advice on it. Maybe other ICBs could help us.
And you're right, we need clarity on this point. But let's go to Carolyn and then Patrick, and then we'll try and wrap it up.
Yeah, so just obviously for the board's understanding, these policies will have already gone through the Integrated Care Board organisational kind of structure internally. The purpose of bringing them to the Integrated Care Board is for that final ratification. So as Patrick's kind of said, they are about the employment policies and the policies that will hold NHS Cornwall and Scilly Integrated Care Board together. But clearly they have to have a point of where they are ratified and signed off, and that would normally be the board. So as I say, they will be the exec's responsibilities, and they will have been cited via the execs and the non-executive members via committees and the committee structure coming to the board. So that all will have been cited. As I say, this bringing them to here is actually then to ratify them.
Patrick?
I request to take the intricacies of their applicability to board members employed by other organisations. I'd like to take that offline and come back with a view on that, if that's.
I completely agree. And so if between now and next time you can get clarity and everyone's happy, we can sign up to it. Yep.
Thank you. Thank you.
Well, great challenge, Mary. Thank you. Right. Let's move on to recommendations and lunch. So we've had the verbal feedback from Brown and Jacobson. You're all happy with that? Yep. I think we've made some observations and comments on the policies that have been shown. Can we delegate responsibility to the chief exec to make any minor changes? Well, I think we're actually asking really for some of this to come back, are we?
Yeah. It's not the changes to come back. It's obviously the who is signing off to come back.
Patrick, you happy with that? Yeah. So could you play back what you think the recommendation is, just for Trudy?
I think it's. I'm not hearing anything about the content of the policies that's being debated. It's more about the specific point that I want to take away is their applicability to ICB board members, and to come back with that.
Sanj, is it on that point?
It's on a point of a policy that's not there. That.
Can we come back?
Yeah. Okay. Yeah.
Can we agree that's what the recommendation in the second that we're going to sign up to as well? Yeah. Everybody happy with that? Done. Now please ask your question.
Yeah, I noticed in part 2 we're discussing climate crisis, and it's one of my responsibilities alongside the committee. I just wonder if there is a plan, perhaps medium long term, to construct a policy around our actions around climate and climate controls within the ICB, because the wording certainly in the afternoon's paper is more suggestion and diagnosis of the state of the problem. Is there an intent to do that? Is that something that's coming from NHCI, or we're doing ourselves?
The conversation this afternoon.
As in this afternoon we discussed whether we should. Right. Okay. Thanks.
Okay. So we'll take that as a decision along with the delegated responsibility. Should there be any minor amendments that come up, and we'll allow the ICB committees, as outlined in the policies, to approve further amendments to the policies where more substantial changes are required. Are everybody happy with that? Yeah. Done. Lovely. Thank you. So let's move on. I take it, Trudy, there are no other questions that have come up?
John, this is the opportunity for those members of the public that have joined the meeting and kind of have been watching this morning to ask us any questions in relation to the agenda. So we normally would go round.
Thank you. So I can see Nigel is on the call. Nigel.
Thank you, John. We've heard a lot about the pressures on the system all through this meeting. Every day, it seems, I get at least 2 or 3 tweets encouraging me to think 111 first. So I'm a little surprised that there wasn't more about the contribution and performance of 111. I get a number of concerns raised with me about it, wearing my various hats, and I had to take the tweet advice and ring 111 myself recently, and I must say I was extremely disappointed with the response, and it would give me pause before I did that again. And I'm not talking here about the delay in answering the telephone, although that is obviously a worry, but what you ring for is to get clinical advice. And it took a very long time for me to get a clinician to come back and give me that advice. And I know that is not just my experience. So I would hope and ask the board to discuss the contribution and performance of 111 at its next meeting, and to consider whether it is adequately resourced to help reduce the pressures on the system. Thank you.
Thank you. Can I invite, I'll use the title first. Can I invite our ICB NHS provider partner lead, Steve, who should be looking after this, to respond to that?
Yeah, thank you, John. And Nigel, thank you for the question. Certainly that's a really important part of our system approach, and some of the aspects that were covered earlier on the meeting by Susan and Carol, and particularly were around attendance avoidance, admission avoidance, alternative provision of care, and 111 as a central part of that. So I'd certainly be supportive of information coming to the next one of these integrated care board meetings in September, setting out the actions which are already underway to help improve the access to that. 111 works very closely with our ambulance service SWAST provider, as well as primary care and the wider system. So I certainly recognise the importance of that service, and the opportunity for us to continue to improve the timeliness by which people can access that essential advice.
Thank you. So is everyone happy to ask Steve to come back with a brief update in September on 111 as the lead provider representative? Everybody happy? Yeah, Steve, happy with that? Yep, done, Nigel. Thank you. Any other questions from the public? I'll pause because sometimes the hands going up take a time. No. Lovely. Thank you so much, everyone. So now I'm able to close the meeting. I'm sorry I'm a few minutes over. I hadn't expected the primary care intervention, but that seemed an important download. So let's close the meeting there. Thank you very much, everyone. We'll see the rest of our colleagues at 1 o'clock for part 2. Thank you very much.
Thank you.
Thank you. Bye-bye.